broader areas of other public health issues. And then in the afternoon, in the mid-morning, we'll have a poster session on HIV and the broader public health issues. So my name is Jared Omolo, and I'm happy to moderate this morning session with Dr. Vedast Ndahindwa, who will be my co-moderator. So without further ado, allow me to introduce the keynote speaker in the morning, and that is Dr. Galikan Ribasira. Dr. Galikan is a medical doctor, and he has a master's in public health and is currently the director of the HIV division. He's the head of the HIV division. He is an experienced researcher and has expertise on HIV surveillance and has previously worked as a medical doctor before his current position with ICAP. And so we are happy to welcome him to give us a talk this morning on where we are on HIV and the current priorities, and to see how what we are doing fits in with the national HIV current strategies and priorities. So welcome, Dr. Galikan.
Sorry. So, is this one? So, there's a one to Good morning, and thank you, the moderator. I'm glad to be here today, this morning, talking or discussing about the HIV epidemic as one of the most aging epidemic. But of course, it will be hard to me to discuss around this epidemic that have been researched for many years, that have been produced so many publications around, as of course we are talking about the epidemiology field. I know most of you here, researchers who have been closely familiarizing with HIV. So I will take you through just an overview of the epidemic control, and of course I will highlight to the key achievement, and I think if we want to discuss around HIV, most of you we can have enough time and discuss more. So those will be like my outlines. I'll discuss about the key component of our national program, but of course some achievement and few of innovation we are applying or approaches to control this epidemic. But of course, the key special consideration whereby we have most affected people, and what are we doing as a program to leave this burden among this special population. So as all of you knows, we have been dealing with HIV since last 40 years, and more than 37 million of people have been affected globally with HIV. And by last year, 37 million and above have been recorded to be affected by HIV. And we recorded up to now around 36 million. So you can understand how HIV has been a burden for us since the last couple of 4 decades. So, of course, if we talk about most affected people, we understand that women will be more affected, even here in Rwanda and globally, and this will bring us to most considering gender disparity while we're addressing this HIV pandemic. Sorry. So, when we talk about the national response, we discuss more about institution and government approaches, like a framework whereby our epidemic is controlled, and as I said, most of it is controlling to the national level by the target of ending AIDS by the next 10 years. But also, we have so many partners, including that we are even acknowledging the presence of our partners to this journey. And most of our thing will be focusing to three entities, that is prevention, care and treatment, and as well as impact mitigation as far as some population are more concerned. So we always know that HIV and AIDS in Rwanda has been impacting a lot of people, and by any chance or by any random selection, everyone here have been affected in any case. So you cannot have any relative here that have been affecting with HIV in this last 30 years here in Rwanda. And we are lucky that Rwanda is among of the countries that are in the way on tragedy of controlling this epidemic, as we shall be in the next slides. So a bit of historical background on how HIV has been controlled in Rwanda. We also know that the first case, and most of them here, researchers and epidemiologists, have been familiarizing with this sort of slide. And as we recorded from the last 40 years, as I say, most of the first case of Rwanda in 81. And from since some program has been built, and few facilities were there, like in the bottom map on my left. You see that by 2004, few facilities was providing HIV services, but we are lucky to say by now across the country, over 600, if not all facilities, including public and private facilities, are providing HIV services, prevention, and even treatment. So we even have to say that like this has contributed to reduce the burden by even 70% of deaths related to AIDS. So by availing treatment, by wide coverage of ART, we achieved a lot to control this epidemic, and we are happy to say that new infections are declining and toward the reducing and at zero infection by 2030 per UNAIDS global target. So what and where Rwanda is standing in terms of like a control profile to HIV epidemic. So we have like a general prevalence to all population aged 15 to 64, stabilized at 3%. But when it comes to the age reproduction, like to 15 to 49, we have been seeing a reduced prevalence from 3% to 2.6. And the incidence, of course, has been reduced from the last couple of 10 years. And we see like a decline in incidence, but as well, the PMTCT rate to prevent this mother to infect their unborn babies have been reduced that below the transmission rate below 1.6%. And across the province, you remark that Kigali, we still have a higher prevalence, but still reduced comparing to the previous years. So I want to pull your attention to age distribution, of course, and we see and we keep remarking that those age below 30s, girls and or ladies or females are more affected, even 3 times compared to their brothers. And most of our effort will be focusing to reduce this new infection and among this age category, mainly 15 to 24. those we call adolescent girls and young women. So, of course, when we deeply in our estimate, we see that new infection has been established around 5,000 per year, but even the case reduced, as I said. But we expect to have like a control of this epidemic whereby this new infection will be less than the death, and expected to be in the next 2 years, whereby we expect in 2025 Rwanda to be achieving the epidemic control, whereby new infection are below the death among general population. And another attention to this is like by the next 5 years, we expect most of the third of our population will be reaching over 50s, and this is to pull attention to the expected association of HIV and NCDs, as most of our population will be reaching the advanced ages, and we expect to see the evolution of NCDs among people living with HIV, simply because those people are not only aged, but of course the stay on treatment will be increasing the risk factor of developing some NCDs like renal disease and even cardiovascular. So most of our research will probably turn toward evaluating the impact of HIV and probably NCDs, and this probably should be expected to have the dual epidemic, or the dual double burden of disease, HIV on top of even NCDs. So where do we stand in terms of achieving control of epidemic? As I've been discussing, we acknowledge the good impact of ART coverage to our PLHIV, and by target towards the UNA's target of 95% people living with HIV know their status, and of them 95 on treatment and suppressing the viral load as well. We stand at the point that the first in 95 is whereby our work will be focusing to find the cases, and most of our approaches will be focusing on case findings to identify people living with HIV who don't know their status and come in treatment, link it to treatment and getting their viral load suppression. But of course, we recognize that young adolescent and people below 30s, they're the one who still lagging behind in terms of achieving this global target, and most of our effort will be targeting to include youth and women in this global target achievement. But again, men's still remain the challenge in terms of accessing HIV services. If we talk about global target achievement and inclusiveness of everyone, we not forget that men still remain our priority, because they're not the one doing well in terms of this program. And most of our research, I would like to recommend that we'll be focusing to understand what's happening among men. If I'm talking this and I'm also one of them, please do not quote me wrong. So where do we stand in terms of eliminating mother-to-child transmission? This is like key achievement, and the global target is looking at in terms of controlling epidemic. And as we wish to keep the transmission rate below 2%, Rwanda is having to work closely hard, like from the past 5 years. The transmission rate was remaining below 2%, and we are looking to increase the uptake among ENC among female living with HIV. And most of our target is for them to be retained on treatment and suppress their viral load that can probably reduce chance to transmit their babies. And by last year, more than 95% of PLHIV mothers attended ART clinic and were directly linked to treatment. So we expected this good initiative and to sustain the gain so that Rwanda will be among the countries that can be selected to those who achieved the mother-to-child transmission and sustained to the elimination. So, of course, medical male circumcision is one of the approaches that prevent around 60 and above % of transmission to HIV. If we have to work closely to eliminate new infection, mainly among boys, VMMC will be one of the key approaches that can be used, and that Rwanda is on keen to it, so that to eliminate the infection mainly among males, especially young boys. So the achievement also marked that Rwanda is more than 40% of males circumcised, but we are looking forward to see an increase even more, to have closer to even 70% in next 5 years, so that male active, sexual active men, mainly those young between 15 and 29, will be circumcised to prevent the HIV infections. But also, I will look to, I'm just trying to give some highlight or key gaps whereby researchers will focused to understand how older men, 40s and above, 50s and above, are not really are not really engaged in uptake to those prevention messages. So one of the innovation that we are putting in place, like to close these gaps in terms of finding out cases, the case-based surveillance is one of them, and thanks to the U.S. government, CDC, USAID, and the entire PEPFAR that are working closely to optimize these services, we are looking a good increase in uptake into the facility whereby CBS is enrolled. And actually what the CBS is to find out cases from the index. So the index in this case will be anyone willing to participate, but also having HIV and not at facility level. So from there, we'll be identifying sexual contact networks or family members that may be linked to that one, that may be in a network of transmission, to find them, link them to treatment, and of course, achieving their viral suppression. So most of them who are familiar, and most of the fellows who have been working to this CBS will understand closely that CBS is one of the most priorities we are focusing to find out those cases and close the first 95 gap. And more than 36,000 contacts have been pulled into program, and of course, whenever contact is notified, is coming to facility, get tested, and from the contact we get contact and we get contact. So we want to closely maximize this approach, the transmission, but also finding out the unknown cases to stop and eliminate potential transmission. So another approach that we are really putting into priorities is recent testing, and these are the new infection less than 12 months, and of course you understand the infection is new and highly transmissible with a higher viral load, because this is not someone who is even not on treatment, and most of the program effort will focus to optimize the recent testing at facility level, even to increase the facility and the coverage of recent testing to find out new infection, link them on treatment and reduce possible transmission. But I want to, again, to pull your attention to the percentage of recents among those young people below 24. And we keep remarking that to this extent, around 60% of these infections are occurring around boys. And of course, if we map those infections, we see that Kigali is among the hotspot we have, and the clusters more are closer to Kigali, but eastern provinces and some cities of the western province, Rubavu will be more our focus in this next fiscal year to understand what is really happening to these special regions. So mapping new infection will help us to timely act, but of course to even understanding the dynamics of epidemics around these special places. So of course, PrEP, most of them have been crossing with pre-prophylaxis, exposure prophylaxis. These are the treatment that are given to someone who is negative but exposed to limit the transmission, and of course to optimize that status of remaining negative. And from starting the last 2 years, 2 to 3 years, female sex workers, MSM, and discordant couple were the key population that are targeted. Those are the people with high exposure, but of course with hard to reach and to retain in routine prevention services. So we have been adding the adolescent girl and young women as another group of priority that is most affected as well with this transmission, but of course looking forward to reduce this new infection among these young girls, because those are the ones who will be next transmitting to their babies and keep increasing the yield if nothing is done to reduce infection among this special group. So on top of other existing prevention mechanisms, PrEP will be another area that will be focusing on it to just reduce infection and probably keep the target to achieving zero infection by the next 10 years. So one of the special considerations I would like to insist on is the prevalence higher among key population, female sex workers and male who have sex with men. Of course, Kigali will still be the province with higher prevalence, and of course we keep recognizing and we keep observing, like some provinces, eastern and western province, will be keeping the higher prevalence, and most of our effort will be focusing again, and I'll pull attention to your research to really understand what is the epidemic dynamism around this special population. Of course, they are hard to reach, but of course, even other prevention services provided to health facility are not optimized by this special group. And most of our effort will be to understand the prevention approach at community level, so that these people can be easily accessible and limit the transmission. Those are the hotspot and probably the drivers of infection. As compared to the general prevalence of 3%, we keep looking at even the female sex worker has 10 times a higher prevalence compared to the general population. So this will be a special consideration and a high point of investment in our program in the next coming years. General, of course, adolescent girl and young women will be linked to PrEP. Those are like key figures of them accessing PrEP, and we are looking to have more or to optimize the coverage so that those key population will be targeted, and maximizing the prevention services combined, whether prevention, biomedical and non-biomedical, to limit transmission as they are considered as drivers of infection. Of course, by this time, as you know, we are in the midst of fighting against COVID, and the COVID will have to assess the impact of it on our program. And of course, yet we still have time to assess the impact after these 2 years of COVID. But we see like the linkage and the movement of our population to services reduced. But again, to the right slide, you keep recognizing that the uptake of VMMC has been reduced during those lockdown periods. But we are lucky that our services are decentralized to the facility level, and everything is accessible at facility level. That but still yet we still have time to evaluate the impact, and also again pull your attention as researchers and epidemiologists to focus on this coming time to assess the impact of COVID on our routine services, yet still not to be noticed. So to conclude, of course, the HIV epidemic is one of the stable in this country, as have been seeing the achievement toward the global target. But a lot still we need to closely work on the prevention, but optimizing the targeted intervention, guided by, of course, by evidences. Because this will be, as you all know, that HIV still yet doesn't have a cure, treatment, and even vaccine, though there's some progress and scientific work around to find out if we can get again the vaccine and the long-term treatment. But again, still we need to still work closely to sustain the gain and limit the transmission and keep our PLHIV on treatment and aging normal. So evidence-based approaches will also be one of the leading point to sustain this gain, having good data, having researches, providing evidence to inform our intervention, of course, because we are not in the era that we are covering everything, but we are targeting according to the need. And of course, we will closely work to the community to reduce transmission and even to sustain the retention among peer education and demand creation to prevention services by again guided with available evidences. So it will be closely sustained again by optimizing the linkage, timely and same-day enrollment and facilitating the linkage mainly among those people hard to reach and key population that are considered like drivers. So also we should keep, we are focusing, and it's a priority to keep monitoring a good M&E system, whether for treatment and even prevention, to just timely inform the need and closely work to optimize the coverage among people in need. So I will pause here. I was saying that when we want to talk around HIV, we can even spend a whole day, but I was just giving an overview of where the epidemic is and how the national program is closely working with partners to sustain the gain and even to close the gaps. But again, I didn't talk much around TB, but I think we also know that TB is a leading cause of death among PLHIV. And as Dr. Patrick is around, we shall have a round of discussion to really closely understand the co-infection TB and HIV. And by here, I thank you very much, and looking forward to have some discussion, point, insight. Thank you very much.
Yes. Thank you. Thank you, Gallican, for yes. Can you have a seat, please? We can proceed with a round of questions, comment for this around this presentation. So, any comment, any question, please? Can we have mic to the audience, please? There is.
Thank you, Garkan, for this overview of HIV that you gave us. I have 3 questions that I want to ask you. That you said that you are in control of the epidemic by initiating CBS case-based surveillance, but most of the time we had a question about the children under 18 years which are willing to disclose their partners. But by now, as what I know, the program is not allowing. How we will control the epidemic among those children under 18 years? That is my first question. My second question is that there is a program called PrEP. In the PrEP, they give the PrEP to the key population and the discordant couple which are not suppressed. But we face the question, an issue of the discordant couple which are disclosed, but who are willing to take these prophylaxis. By now, the program is not allowing. What do you think about those discordant couple? The third question is that there is a project that is supporting key populations for testing and follow-up. There is some facilities that are selected for key population for follow-up. Some of them, they give some amounts for testing. This, I see that it could bias our prevalence, since most of the facilities who follow the key population, they have the prevalence, high prevalence, has a positivity rate. What do you think about this? Thank you so much.
Thank you.
Okay, thank you. My name is Jean Savomukiza. I'd like to ask 2 questions. First of all, I congratulate RBC and the program with the strategic plan that has been put in place, with the improvement that has been done. The first question is about the strategies that you have in order to control the transmission of HIV within the sexual workers and even homosexual people while they're working in shadow as the sexual worker are not legally permitted to work. The other question is about the integration of HIV program and also ARV services within the health professionals. As you know, we have mentors, medical mentors and also nurse mentors who are working to mentor the health centers and also ARV services. But HIV protocols and guidelines changing many times. So I would like to know if you have also a plan to integrate within the other health professionals, not only mentors.
Okay, good. The next question.
Thank you, Dr. Galikan, for the comprehensive overview of the program. I have 2 questions. The first question, yesterday we learned quite a bit about cluster investigations and some policy implications following from that. I wonder if you could comment on some of the cluster investigations surrounding the recent infections among HIV. My second question is, you also showed a slide about the impact of COVID. I wonder if you could also comment on the impact of COVID on the laboratory aspects. I can assume or imagine that with a lot of testing on COVID, that some impact was felt on viral load testing, etc. Thank you.
Thank you for these questions. Maybe you can allow the speaker to first address this round of questions, then we can come back if any, please.
Thank you very much. Yeah, I've received like 5 to 6 questions that I will probably talk around, and discuss. But I know some of the participants here present could be having a say on this. Like if I ask Tom to discuss around CBS, he will be better explaining that. But I'll talk few of the point, and please feel free to chip in if you want to discuss around CBS and reasons. I'm clearly talking about the CDC people. So Fetp CBS, he asked about CBS among these girls or children below 18. But here I want to clarify that CBS is also offered to indexes even below 18. But of course, we need to understand that this is a consent that is needed, and you need to have a consent for enrolling a PLHIV below 15. So we don't limit to 18. But of course, we need to make sure that whenever we engage to disclose sexual contact among these children under legal age, we need to have some special consideration and working closely with GBV services. So we need to have a proper referral to GBV services. But of course, you understand age of legal practice here in Rwanda is still kept under above 18, and I think to our program we're not close to we are not binded and attached to this legal aspect, but we understand that there is a GBV consideration that we need to closely follow, and most of our services are linked to referrals to GBVs when it comes to disclose sexual partners to less than 18 years. So CBS is still considering this age category, but we need to understand that legal aspect and GBV cases when it comes to sexual activity below 18 years. So we also asked about PrEP among discordant couples that are suppressing viral load. I want to point that that PrEP is an additional prevention services to other existing services, and we want to optimize these services to these people hard to reach, and defaulting in any means to the routine prevention services. So if the couple is well followed and the viral load are suppressed, we also understanding the untransmissible linked to undetectable viral load, it's better that they are optimizing or they use other existing means, and PrEP will be mainly given to those people who are hard to reach and not suppressing their viral load. But of course, this was a starting, and if the need is assessed and judged to be real, we shall even extend to this suppressing couples. But for me and scientific point of view, they don't need to be linked to this. So, but of course, we shall understand that we keep considering and evaluating the risk. If the risk is judged to be more imminent, that also be directly linked to and offered these PrEP services. I've also been asked to discuss about a follow-up of key population and some organizations that are offering incentives. This is a sort of malpractice that we are discouraging. You know that we have so many actors in this program, and by effort of finding out cases and reducing transmission around this key population that are really constantly hard to reach, we need to apply means and encouraging them to come and link to the facilities. But again, we discourage this because this is not a harmonized way, and this is not a sustainable approach to engage someone into care and services. So if already, even if it's happening, we know, and please point somewhere you keep seeing these practices, and we shall closely work as a program to address these issues. It's a malpractice, and we're really discouraging it. So Jean asked about strategies that we have to key population, mainly female sex workers and these males who have sex with males. Of course, these are the key population, as I highlighted, and is considered to be a priority in this coming era. But of course, there are good progress that we see to enable us to reach this population. As you know, by 2018, the government adopted a law decriminalizing this female sex workers and MSM, and this is a good enabling step for the program and other organization to reach these people and for them to access mainly the prevention services. So we have them into program, and we are closely working with the community-based organization to actively reach these people and optimize the service delivery among this special group that are considered like drivers of infection. And you even talked about integration of HIV services beyond clinical mentors. And of course, this is a need, and by considering sustainability of our services, it's better that our trainings will go beyond even clinical mentors. But of course, I know that those mentors are not trained to be only mentors. They are trained to even escalate that training and expand the training to their workmate. So they are trainers by profession, and they should be probably extend this training they have got for quite so long to even have other facility and healthcare providers to be familiar with HIV services. So whenever you see in a facility, these mentors are not facilitating training, they are not engaging other healthcare providers, it's another sort of, again, of malpractice that we even, again, discourage, and they are trained to even train other trainers. And probably most of our training in coming years will be facilitating to extend the training even beyond those new staff who are not yet trained. So again, to talk about sustainability and integration, as I was talking about integration of NCDs and HIV services, we are closely having program to reduce the burden of visit to health care providers working in HIV by multiplying the drug mass pickup. That will be facilitating them to even engage in other activities and services being integrated in other clinical work. So NCDs, hepatitis, STIs will nearby be integrating into HIV services, and shall be closely work with health facility to understand this concept, because we want the epidemic to be sustainable, but also sustaining the gain that have been achieving in controlling the epidemic. So Dr. Cherry asked about the cluster investigation for this recent infection. But of course, this has been like starting in early 2018, and quite many clusters have been discovered, but of course there has been work to identify and bringing together a component to make a case definition of cluster. And clusters are considered like 2 or more cases in a facility, but happening in a couple of 30 days within that same month of reporting. So this is considered as a cluster, and a team assigned to support the HIV prevention services will be visiting and the facility to clearly understand there's a strategy, there's an SOP to conduct this cluster investigation, and the team will closely work with the health facility to understand the dynamics of infection around these people in a cluster. And most of the cluster have been linked to indexes in these many clusters who have been contacted, and mainly the young age are most seen in these clusters. People below 30s are most getting infected, as we see the new infection is more focused and occurring in the young generation. So we shall keep working closely with our partners to improve this cluster investigation, and probably if the time means, we shall even have to revise our case definition to clearly understanding according to the region. If a region is not having a case for or facility is not having a case for 6 months, if it happened 2 or more in 2 consecutive months, that would be like considering to be a cluster compared to the facility and according to the previous records. But of course, having this, it's more optimizing the recent testing and the coverage across these health facilities. He also wanted to discuss around the impact of COVID on testing, and this is again the impact that need to be yet evaluated, because those testing hub have also been serving to test even COVID, and we have been recording a backlog of viral load testing for HIV. But our effort has been closely working to multiply the testing and using platforms that can facilitate both COVID and HIV testing. So we still have this impact, and we are closely work with our partners, CDC and other partners to really mitigate this impact, because it has been already noticed that COVID has impacted our viral load testing, and yet still have even COVID and HIV to manage. So thank you very much, and I hope I tried to pass around all those questions, but if anyone has to add on my comment, please feel free. Thank you.
Thank you, Galikan, again. Any additional suggestion, comment, or question? Yes?
Okay. Yeah, thanks so much. Yeah, I was just going to add on to what Dr. Galikan said about the cluster investigation. Yeah, I think he rightly said the definition, is 2 or more recent infections. And beyond, those cluster investigations, there's a programmatic use that is getting into, especially identifying, for example, cases in discordant relationships, and identifying negatives that will become eligible, say, for PrEP and other prevention measures. The other thing is identifying hotspots with likelihood for transmission. So some of those hotspots have been identified as markets or commercial centers, and also large-scale farming areas, which then qualify for targeted prevention measures to to disrupt the risk of transmission of HIV. So we are getting more and more deeper and deeper into the analysis and doing those cluster investigations, and then using that for public health response. So.
Thank you. I'm not seeing any raised hand. Maybe Galkan, you can address that, then we close.
Yeah, thank you. I think it was a comment and to add to what I've been discussing. Thank you, Dr. Tom, for the comments.
Okay, thank you very much. Thank you, Gallican, for the presentation and addressing comments. We can now move to the next presentation on the agenda. That will be, our next speaker will be Ines Itanga. Ines is an FLTP alumni. She's currently working at RBC as a surveillance officer. She had worked for more than 10 years as environmental health officer in different hospitals in Rwanda. She is a team member of the National Outbreak Rapid Response Team and has played a key role in responding to COVID-19 pandemic in Rwanda and in different ways: data management, contact tracing, case investigation, mass testing, etc. She's an FLTP frontliner trainer, and she's a member of the scientific committee that had organized this conference. She will be speaking to her research on opportunistic infections and associated factors among HIV-infected adult persons on antiretroviral therapy in Ruhengeri Referral Hospital, that's in Rwanda hospital. So it's a cross-sectional study, so welcome.
Good morning, everyone. My name is Ines Itanga, as the moderator said, and I'm going to present to you the findings from research from a study conducted on opportunistic infections and associated factors among HIV-infected adult person on ART in Ruhengeri Referral Hospital. We go through our background, the methodology that was used, and present to you the result and then the conclusion. Opportunistic infections are more frequent or more serious infections due to the immune suppression in HIV-infected individuals. Their occurrence affects the natural cause of the HIV infection as HIV viral load increases. This study aimed at assessing the prevalence and factors associated with the occurrence of opportunistic infections among adult patients on antiretroviral therapy in Ruhengeri Referral Hospital. It is a cross-sectional study that targeted HIV-infected patients enrolled in Ruhengeri Referral Hospital from 1st January 2007 to 31st December 2017. We included a patient who were aged 15 years old and above. Data were extracted using Excel sheet, then analyzed using Stata version 15.0. The data that were extracted were about social demographics and clinical aspects. The opportunistic infections were based on clinical diagnosis. The prevalence of opportunistic infections was determined as the proportion of HIV/AIDS patients on ART who developed one or more opportunistic infections. Crude and adjusted odds ratios and 95% confidence intervals were used to describe the strengths of association between opportunistic infection and possible risk factors. This study was approved by the Institutional Review Board from the University of Rwanda College of Medicine and Health Sciences. These are the results we found from the study. After the selection involved 423 records from on patient on ART. The mean age of patient was 23 years old, and the majority were female, representing 64.1%. The majority were living in urban area, 42% were married, 54 were farmers, and 57% had primary education level. Pre-ART had been provided to almost all patients, that 97%, and in December 2017, 75% of participants had spent more than 5 years on ART. At ART initiation, 40% of participants were at WHO clinical stage 1, and CD4 count were between 200 and 499 for the majority of participants, and 92% were at the first-line regimen. The prevalence of opportunistic infection were 9.2%. As of the 423 recorded reviewed, 39 had diagnosed opportunistic infections. There were 16 of them of opportunistic infection that were diagnosed in 39 patients. Among patients who developed opportunistic infections, 10% had at least 2 infections. The most frequent was tuberculosis, representing 20%, followed by oral candidiasis, pneumonia, and STI with 15.6% each. And after analysis of conducting bivariate analysis of the social-demographics, characteristics, and clinical variables, those which were significant on bivariate were transferred to the multivariate analysis and went up with these 3 significant variables, which are being jobless and spending more than 5 years on ART and starting ART at W clinical stage 3. We conclude saying that opportunistic infections are still challenges among patients receiving ART in Ruhengeri Referral Hospital. Therefore, there is a need to strengthen the management of opportunistic infections despite the use of ART. And also, there is a need of effort to be put in follow-up of patients, not only providing ART, but also in socioeconomic strengthening, as well as keeping the momentum towards treat all HIV-infected people. That is a policy which is under implementation in Rwanda. This study couldn't have been possible without the involvement of these institutions that are acknowledged here. Thank you for your kind attention.
Thank you, Ines, for the presentation. The second presenter will be Daniel Tabanganyimana, who will be presenting on predictors of loss to follow-up among people living with HIV receiving antiretroviral therapy in Nyarugenge district. Daniel is a statistician background and was in the 5th cohort, and currently works as a health sector M&E and reporting specialist in the Ministry of Health. So welcome.
Direction, yeah. Good morning, everyone. I'm going to share with you the findings of the study conducted on predictors of lost follow-up among people living with HIV and receiving antiretroviral therapy in Nyarugenge district. What is problematic with lost follow-up is that lost follow-up leads to poor health outcomes that include failure to suppress drug resistance, increased morbidity, hospitalization, and mortality. And this really, if not well investigated, lead to threaten the current gains and benefits from ART. So we need to know about lost follow-up and investigate them well so that they are not threatening our gains got from the ART. So, however, we don't know much of lost follow-up. Little is known about it. The study aimed to estimate lost follow-up rates, to first lost follow-up event, and to repeated lost follow-up within a cohort of people in 2 years after ART initiation. We aimed also to determine predictors of first event of lost follow-up and repeated lost follow-up within that period of 2 years from ART initiation. We did a retrospective cohort study of 24 months of people who started ARV between January and December 2018. We abstract data from linkage registers and patient files in 12 health facilities of Nyarugenge district. We collect data on social demographic, clinical conditions, biological, and medication variables also. A lost follow-up was defined as a patient who had no record of contact with the health facility for 3 consecutive months. Excel and Stata version 14 were used for data management and data analysis. We calculated proportion of social demographic and clinical characteristics and expressed them in percentages. We also calculated incidence rates of lost follow-up and expressed them by per 1,000 person months. We used Cox proportion Cox proportion hazard rate ratios to determine the predictors of time to first lost follow-up event, and we used generalized estimating equations to analyze the repeated measurements of lost follow-up among and predictors of repeated lost follow-up. Going to the result, our total participants were 950. A majority of them were female, 61%, and a big portion of them, 91%, were aged between 15 and 49 years. Married represented 45%, whereas those who are in self-employment were 47. We also saw that those who have family members who have reported their family members to the one which can be contacted when they are not reachable represented 74%, while on first line adult and alternative, those who started on first line of reality were 94%. Among those who were TB co-infected were 21, meaning 2% of the total participants. A big portion, also 77%, were on WHO stage 1. Of the total participants, 148 participants got lost follow-up for 551 times. And the incidence rate to first event of lost follow-up was 7.8 per 100 person month, while the incidence rate of lost follow-up to multiple lost follow-up was 26.5 per 100 person months. When you go to factors which was found to be associated with first event of lost follow-up, we saw that marital status was strongly associated with first time to lost follow-up, employment status also, and contact person, but also the stage, the WHO stage. Whereas single PLHIV had double risk, have 2 times the risk of being lost follow-up. And self-employed people, when compared to employed people, has also 1.9 times the risk of being lost follow-up. And the people who reported a contact person who is not a community health worker or a peer educator have more than 5 times the risk of being lost follow-up. And for the multiple or repeated lost follow-up, we saw also that single people living with HIV being single was associated to being lost follow-up for multiple times. We also found that being self-employed and having a contact person who is not a community health worker or a peer educator and residing out of the catchment area, as well as being on adult first line or alternative line, were also strongly associated with being lost follow-up for multiple times. Our conclusion is that we have lost follow-up, especially in single, self-employed, living outside the health facility catchment area, and those having contact person who are not community health workers or peer educators. We saw that they are the factors which are leading to being lost follow-up and for multiple times. We recommend that community health workers and peer educators can be used to reduce lost follow-up among those people. We also recommend to explore targeted sensitization services delivery to those people, meaning single PLHIV on reality, self-employed,
and those living out of the health facility catchment area. I want also to acknowledge those institutions which helped us to conduct this study. I thank you.
Thank you, Daniel, for the presentation. So now we are moving to the next presenter, who will be Adeo Sanzubuhoro. Adeo Sanzubuhoro is a resident in the FHP program, and he's currently working as clinical nurse at Kibungo Referral Hospital. He will be speaking to his research on predictors and prevalence and predictors of non-communicable diseases among adult people living with HIV/AIDS in Ngoma district. You are welcome.
Good morning, everyone. Yeah, I'm happy to share with you the findings of my study conducted in Ngoma district about prevalence and the predictors of non-communicable diseases among people living with the HIV/AIDS in Ngoma district. Mainly in 2020. As the moderator said, my name is Nsanzuholo Adeo. I'm a resident in Fetp, University of Rwanda. The background, as Dr. Rwibasira said in the introduction, NCDs are major problems among people living with HIV. Mainly, not only among those people, even in the general population worldwide, in developing and in developed countries, high-income countries, middle-income countries, and low-income countries, NCDs are becoming major public health problems. Especially the burden of NCDs is increasing among this group of people living with HIV, and the increased prevalence depends on different factors, but here I mentioned aging, as the doctor said, and different literatures. There are success of HIV programs and ARTs that are leading to elongated life of people living with HIV, as many of those people are living in the 50s of age. Traditional NCDs risk factors, including obesity, unhealthy diet, sedentary life, and so on, and direct consequences of HIV, and also drugs. Some ARTs are said to be at the cause of some NCDs. Yeah. NCDs are the leading cause of death worldwide. WHO reports of 2017 estimated 70% of deaths to be caused by NCDs. And as I said, people living with HIV are living longer. And also the most prevalent NCDs among people living with HIV include cardiovascular diseases, all types, cervical cancer, depression, diabetes, and COPDs. Also, in different countries, there's scarcity, or even you cannot, there's some countries you cannot find data about the magnitude of the burden of NCDs among people living with HIV. And this was also among the motivation of this study, as there is no enough of data. We want to collect and analyze data about NCDs. Objective of this study, we had like two objectives. The one was to determine the prevalence of 5 major NCDs selected, including hypertension, diabetes, mellitus, cervical cancer, asthma, and chronic kidney diseases among people living with HIV in Ngoma district, and then to determine the factors associated with these NCDs in that group. Methodology, this was designed as a cross-sectional study, and it was conducted in 13 health facilities located in Ngoma district, including one hospital, which is the district, and the referral hospital, and 12 health centers. And also the population were people living with HIV, aged 18 years and above, who were under follow-up in those health facilities. And the sample size calculated was 422, including 10% non-response. And the population, the sampling technique was simple by simple random sampling from the appointment registers at the health facilities, and also this total sample was distributed proportionally to the health facilities according to active people living with HIV registered to the health facility. We used the structured questionnaire developed in EPM4 to collect data, and also most of these NCD questions were adopted from STEPS tool for WHO to survey chronic diseases. And data were collected by professionals, nurses, and the lab technician through interview and patient file review. Also, we collected some anthropometric measurements, including weight, height. We calculated BMI, and also measured waist circumference of the participant. And also, we collected some samples, blood, and for blood glucose, we measured glycemia for participant, and we tested glucosuria and proteinuria. Then we also examined a lab test recorded in the patient files for creatinine, and we calculated creatinine clearance. NCD definitions. Hypertension was defined according to American Heart Association guidelines of 2020. Every participant whose blood pressure measured systolic blood pressure above equal or greater than 140, and the diastolic equal and greater than 90 millimeter of mercury. Diabetes also was defined according to American Diabetic Association guidelines of 2020, and every participant who's reported to be known or registered in NCDs and whose glycemia was greater than 125. Also, asthma kidney disease, and the outcome variable was having one or more NCDs. Result to the method, the consent form was sent by every participant. Result, the total participants who consented and participated were 413. Most of them, majority were female sex, 63%. And median age were 49 years old. And 68.4% of participants had primary level of education, and 96.4% of participants were farmers. About HIV and ART clinical parameters, yeah, thank you. 60% of participants lived with HIV more than 10 years ago, 10 years. And also 52% were under 10 years on ART, and 86% were on first-line treatment. And according to clinical staging of HIV, the majority were in stage 1. And the viral load, majority had suppressed on the CD4, who had low CD4 were 39.4. According to the lifestyle, 5% of 5.5 of participants were only currently smoking, and 28.9 of participants were alcohol consumer. And to the nutrient, as you see, fruit consumption, 3.3% consume fruit over 5 days. And 5.9 of participants had family history of NCDs. And 22.4 of female participants were screened for cervical cancer. The prevalence of these NCDs, the prevalence of diabetes was 4.3 among all participants, while hypertension was 16.6. The most prevalent was chronic kidney disease, or simply kidney disease, was observed among 58.3 of the participants. And the prevalence of having either one or more NCDs was 65.1. Factors associated with NCDs, having one or more NCDs among these people, 4 factors were identified to be statistically associated with this, with having one or more NCDs, including female sex, age more than 55 years, and the CD4 count more than 200, and the history of STIs. Conclusion, as we concluded, the NCDs comorbidities was high among people living with HIV in Ngoma district, and we didn't find cervical cancer and asthma among these people, and the chronic kidney disease was the most prevalent. We do recommend continue follow-up for people identified having NCDs, and perform regular screening for NCDs among people living with HIV, conduct further studies about NCDs among the risk factors and their risk factors among these people, and the regular personal medical checkup. Thank you for your kind attention.
Thank you, Adeo, and thank you to the presenters. So we're going to take some questions and discussion and comment. Mike? Is there any comment? Yes, go ahead.
Thank you. I had a comment or a question for Ines, the first presenter. I didn't see from your presentations whether you looked for if patients were adherent to their medication. And secondly, if some of these patients, it's striking that TB was the main opportunistic infection. I wonder if some of these patients had been put on TPT or TB preventive medicine. And if not, it shows the importance of doing that. And then finally, what was the outcome? Did all the patients survive their opportunistic infections, or did some of them unfortunately passed away? And then my second question is for Daniel. Nice presentation, but I wonder if you also did some qualitative investigation and approaching the patients, asking reasons why they were lost to follow-up, why they stopped coming to the facilities for their treatments. Thank you.
Thank you. I think there's no more questions. Yes, please.
Thank you. Congratulations to Adeo for the good presentation. I have just one comment on the analysis of CD4. You mentioned above 200 and above 500 in the model, and I think you need to check if they are not correlated. Otherwise, you better maybe analyze CD4 as one variable. Thank you.
Okay, good. Yes, there is one question there, or comment. And that one.
I have a question for Adeo regarding the cervical cancer. You said that among the participants, no one had cervical cancer. Have you screened them, or it was by asking if they have cervical cancer or signs of it? Thank you.
Thank you. Yes.
Okay, thank you. Congratulations to all presenters. Just one question to the first one. Maybe I missed it, but it could be better also to see either the viral load or the CD4 for those who presented the opportunist infections among people with HIV. Another question was, we saw that tuberculosis was among the first IOs among the studies, and what could be your recommendation? Thank you.
Okay, thank you. Now our speakers, let us your comment addressing these questions. Ines, or can we start with Adeo?
Thank you.
Go ahead to your questions, yes.
Yeah, as Dr. Marie-Aimée asked, the methodology used to assess cervical cancer, we asked the question, the participant, we didn't examine. We asked if she has been screened or diagnosed of cancer, or if she did, she answer yes, we ask if she knows she has cancer. She said no. Yeah, that's how we examine it. From those yes and no answers, we find no one answered yes to have been diagnosed or screened positive cervical cancer. Thank you.
Okay, thank you, Edeo. Ines?
Thank you for the questions asked. The first one was if we recorded data about the adherence to ART. This was recorded, and most of the patients had adherence above 95% of their adherence from their files. And we ask also if for TB, if there is any treatment provided for prevention. In our study, the priority treatment was provided to almost all patients. At the initiation, when they were tested positive, priority was provided to more than 95% of the patients. About the outcome, if they are still alive or dead, we are sorry we didn't record this. We didn't record any data about their outcome, if they are still alive or dead. The other questions about that was asked, it was if the patient with opportunistic infections, if we recorded the viral load or CD4 count at the time they were having these infections. But also, we recorded data on viral load and CD4 count at the beginning of when they started the ART treatment. The recommendations about the TB, as it is the first of it was the infection that was recorded among the most of the patients. The recommendation regarding this is regular screening as they come for follow-up and treatment accordingly. Thank you.
Thank you, Ines, for addressing. Then, last but not least, Daniel.
Thank you. I have received a question about whether we've gone a step further and asked people living with HIV who were lost follow-up why. It's really worth to acknowledge that we didn't go that step further, and it is important. Looking at the findings, we can also recommend to go that step further. Thank you.
So we thank you all, our presenters, for this last session. For the sake of gaining time, we have to stop our discussion from here. So thank you very much. So the next round of presentation will be again the new 3 presentation. One will be presented by Mr. Gitera Joseph. Gitera Joseph is currently working at the Ministry of Health. As maternal, child, and adolescent health quality specialist in the Ministry of Health. He has graduated in FLTP. So he will be presenting on the topic entitled Predictors of Low Uptake of Modern Contraceptive Methods Among Women Living with HIV/AIDS, a cross-section study in Nyarugenge district. Please, you're welcome.
Thank you so much for this opportunity. I'm going to present about the predictor of low uptake of modern contraceptive methods among women living with HIV. The study done in Nyarugenge district. Those are outlines. As you may know, family planning is an essential public health intervention, especially in women living with HIV. And some factors may hinder the uptake of modern contraceptive use among women living with HIV. This study aimed to determine the prevalence and predictor of low uptake of modern contraceptive methods among women living with HIV in Nyarugenge district. It was a cross-sectional analytical design with mixed methods, meaning that we used qualitative and quantitative methods, and the study was done in Muhima catchment area, including Muhima District Hospital. Data were collected from 633 women living with HIV, and we used a structured questionnaire, and focus group discussion was used to explore the predictor and the barriers towards modern contraceptive method uptake. And also we analyzed data by binary logistic regressions, and data also was used to analyze data collected, and we calculated adjusted the odds ratio with 95 confidence interval, of 95 confidence interval. As a result, the prevalence of women not uptaking family planning methods was found at 20%. 65 among the participants, 65% were aged between 25 and 34 years, and the majority were living in urban area. Also, the majority were Christians, and 86% had a medical insurance, and 74% were married and having primary education, and 37% were self-employed, while 49% were Nudehe category 2, and 44% were Nudehe category 1. Those are factors associated with low uptake of modern contraceptive. We found that being Muslims were associated to not uptake family planning methods, and this similar to other study conducted in a Muslim country, where they found that Muslims sometimes they are not taking family planning method, pretending that those family planning methods are not good, and they said that preventing childbirth is haram for some of them, and also bleeding after a menstrual cycle is also a haram. And also not having health insurance was also found associated with not uptake of modern contraceptive among women living with HIV. Also, lack of discussion with partners also found 2 times more likely to be not uptaking modern contraceptives. And also intention to use contraceptive in the future. This was asked for the women who stopped contraceptive methods, if they want to continue methods, family planning method. They answered that no, and it was also associated on not uptake family planning methods. Qualitatively, some women highlighted that on modern contraceptive is important for HIV, HIV women, and they said that you can't continue giving birth when you are HIV positive. And what I know is that giving birth reduces blood from the body, hence immunity also reduces, and in my view, it's better to stop rather than continuing giving birth. On my side, I am using an injection of 3 months as a contraceptive method. Another informant, one asked if the family planning is a friendly use. The informant highlighted that it is good because they are easy to use and they have different forms, and I can use one or change to another. Another one said that no need to continue giving birth because you can contaminate your childbirth during pregnancy, childbirth, or breastfeeding. About effectiveness of modern contraceptive, one informant highlighted that we use modern contraceptive methods because they are more effective than nature ones. Also, they are advised healthcare providers they are advised by healthcare providers. On government support and availability of family planning methods, one of the informants highlighted that I am happy that our government avail the modern contraceptive. If I need them, I get them, whether I want to change. When one is not here, I am provided with another one, thanks to the government of Rwanda. Another one highlighted that other advantage is that you are secured for a long time, and there is healthcare providers who makes a close follow-up to you to see if there is no any side effect. About side effects, one of the informants also highlighted that there are some people who this method can cause side effects, and it becomes worse if in people living with HIV. One of my colleagues experienced non-stop bleeding, and it causes her to have a persistent anemia. One of the informants also highlighted that using modern contraceptive and taking at the same time with antiretroviral drugs, there are risks to have the incompatibility and of these two drugs, and it may cause danger in our body. And another highlighted that their husbands don't support them because they believe that their wives will develop the vaginal dryness. So as I conclude, a good proportion of women living with HIV were found not using modern contraceptive to prevent unintended pregnancy, and there is also a risk to vertical transmission of HIV from mother to newborns. So as recommendations, we can recommend to strengthen healthcare providers' capacity to promote, to teach and to deliver a wide range of contraceptives so that women can choose which is eligible for her. Increase women's knowledge about safe and effective and long-acting contraceptive method, improve the partner communication and deep counseling, also having a health insurance, also offering services in a friendly manner. We acknowledge the following. Thank you so much for your kind attention.
Thank you, Joseph, for the presentation. So, we're moving to the next presenter. So the next presenter will be Edward Rusesa. Welcome. Edward Rusesa will be presenting on tuberculosis treatment outcomes and factors associated with the unsuccessful treatment outcome among TB-HIV co-infected patients in Rwanda, data collected from July 2019 to June 2020, a retrospective cohort study. Please, you're welcome.
Thank you. Good morning. Yeah, I'm going to present the findings of our study entitled TB treatment outcomes and factors associated with unfavorable TB treatment outcome among TB-HIV co-infected patients in Rwanda from July 2019 to June 2020, and it is a retrospective cohort study. Globally, TB is the leading cause of death among people living with HIV, and according to WHO report of 2019, among new TB cases reported, 8.2% were people living with HIV, and according to the same report, among all TB deaths in 2019, 14% were people living with HIV. And 70% of all TB HIV co-infected patients are in sub-Saharan Africa. And several studies have shown that TB and HIV co-infection is a challenge to treatment and aggravates the outcome of TB treatment. Our study objectives were to determine the outcomes of TB treatment among TB-HIV co-infected patients in Rwanda from July 2019 to June 2020, and identify the associated risk factors associated with unfavorable TB treatment outcome among TB-HIV co-infected patients. A TB-HIV co-infected patient was said to have an unfavorable TB treatment outcome if his or her TB treatment resulted in treatment failure, lost follow-up, or death. We extracted data from the electronic TB reporting system that is used nationally, and in the analysis, we included all TB-HIV co-infected patients reported in the electronic TB reporting system during that period, and whose treatment outcome was recorded. This figure shows the recruitment of the participants, where initially we had 1,144 patients, and 13.7% of them were excluded from the study because some of them were not evaluated some had no treatment outcome recorded, and those who were on the second line treatment, those who were lost follow-up before the anti-TB treatment initiation, and those who died before the initiation of anti-TB treatment. And then frequencies and proportions were calculated using Starter version 13. Bivariate and multivariate analysis were calculated at 95% confidence interval, and the p-value less than 0.05 was considered as statistically significant. The social demographic characteristics of our study participants showed that 98% were above 15%. Here I did not put it, but the mean age was 40 years, and the age range was 1 year to 93 years. And as you can see, 44% of the study participants were from Kigali City. And about the clinical factors, 86% had pulmonary TB, and 78% had bacteriologically confirmed TB. Surprisingly, 6.7, almost 7% were recorded as not being on ART, and 82.6% were on cotrimoxazole preventive therapy. And 52% of the study participants had a body mass index below 18.5. So these are the outcomes of TB treatment we found, whereby the unfavorable TB treatment outcome was reached by almost 20% of the study participants. And among the unfavorable treatment outcome, 14% was due to death of TB HIV co-infected patients on treatment. And in bivariate analysis, TB HIV co-infected patients who were not given nutritional support, those who were clinically diagnosed, those who were on ART, who were not on ART, and those who were not followed by community health workers were more likely to have unfavorable TB treatment outcome. And these significant variables in bivariate were put in multivariate logistic regression, and the factors independently associated with an unfavorable treatment outcome were not being given nutritional support and not initiated on ART. So in conclusion, unfavorable TB treatment outcome was high among TB HIV co-infected patients, but also mortality among this group was high. The factors independently associated were those not initiated on ART and those that were not given nutritional support. So from the findings, we recommend that to reinforce nutritional support to TB HIV co-infected patients, early initiation of ART to all TB HIV co-infected, and because we found the mortality was high, we recommend to conduct a study to assess the factors associated with the high mortality among TB HIV co-infected patients. Thank you for your attention.
Thank you, Edward. I'm pleased to invite the last presenter for this session, but not the least. That will be Angela. Umutoni Angela. Angela is working at Rwanda Biomedical Center as Public Health Surveillance, Emergency Preparedness and Response in Response Division. She will be presenting on factors associated with successful partner notification of HIV positive index clients in Rwanda. You're welcome.
Thank you. Thank you. Just like the moderator had said, my name is Angela Omutoni, and I'm happy to be presenting research done on factors associated with index testing and contact and partner notification of HIV patients in Rwanda. So, next. So I'll talk briefly on the global summary of HIV because Dr. Gallican had already touched on this. So globally, HIV infections range from 3.37 million. Okay. Give me a minute. I have a sight disability, so you bear with me. Yeah. Okay. Next. Yeah. So, like I'd mentioned, globally, the HIV infections range from 37.7 million. Whereby adults account for 36 million. And then in 2020, new HIV infections ranged from 1.5 million, whereby women were affected most by 6,060 HIV new infections. So going to the background of HIV epidemiology in Rwanda. Yeah, so currently HIV is, basing on the RFIA study that was conducted in 2019, HIV in Rwanda is about 3% prevalence, whereby 2,030 people live with HIV. Most of them being female sex workers, whereby they account for 45.8% of the prevalence in Rwanda, followed by MSM, men who have sex with men, whereby they account for 9.2% of HIV infections. So the current incidence of HIV in Rwanda is about 0.08 per 100 person years. And male circumcision being at almost 40%, coming from 13 that had been detected in 2020. So going to the 1990 target, the UNAIDS target in Rwanda, where are we currently? So we are currently at 84% with people that live with HIV that know their status. So you can see that we have a gap of about 6%, but given the approaches that are being put in place, the 6% is will also be reached. So, currently we are also at 97% of people with people living with HIV that are on ARTs, and then 90% of the population of the people that live with HIV have suppressed their viral load. So, going to the next slide. So basically, to achieve the first 90s, one of the strategies that Rwanda is implementing is index testing and partner notification to be able to reach partners of HIV index cases in a more active way, since the passive referral mechanism has been quite not effective in finding HIV cases. So in index testing, so what do we term as index testing? Index testing is an approach whereby all family members and sexual partners of HIV, of newly tested HIV positive cases, are identified and linked to HTC, HIV testing services. And partner notification is a voluntary process whereby newly tested HIV patients are encouraged to bring in their partners for HIV testing and link them with the healthcare providers to get tested and know their status. So the general objective of this study were to, one, assess the factors that were associated with successful notification of partners among HIV index clients attending health facilities in Rwanda. And then from these, we aligned this general objective with the specific objectives, which among many were to look at the prevalence of partner listing and successful notification among partners of HIV index clients in Rwanda. And we also wanted to look at the social demographic characteristics of partners of HIV index clients that had attended these 23 health facilities where index testing is conducted. And the other objective was to assess the predictors of successful notification rates among partners of HIV index clients, and to also look at the HIV serostatus rates among tested partners and among tested partners of HIV index clients in health facilities that implement partner notification. So going to the methods, so these are the methodology that we used. The study was a cross-sectional, retrospective cross-sectional study. And the data sources that we used the case-based surveillance database that captures HIV index client and partner demographics, health status, and variables related to both health facility demographics and clinical characteristics. The setting was the case-based surveillance system is implemented in 23 health facilities in Rwanda. So, and this is also implemented using three strategies. One being the client referral arm, whereby an index client is asked to self-disclose his or her status to the partner and bring them for testing. The second approach is the provider referral mechanism, whereby a provider facilitates the index client to disclose the index's serostatus to the partner and and encourage the partner to come in for HIV testing. And the third referral arm is the dual referral, whereby providers and HIV index clients disclose to partners their status and offer them HIV testing services. So our inclusion criteria included index cases of age 18 and above years that had mentioned to have had current sexual partner or any other partner within the past 12 months. And as a partner, the inclusion criteria was any person of any age that had been listed as a partner by an index client within the last 12 months and had locator information and consented to come in for testing. So the exclusion criteria for this study were individuals aged less than 18 years, since they are not part of the people that are enrolled in the CBS index testing program. So the sample size was a take-all approach. We did not need to calculate a sample size because we initially reviewed all the data that had been captured by the CBS program. And then statistical analysis, we used a logistic regression to calculate crude odds ratio, adjusted odds ratio, 95% confidence intervals, and p-values. And for p-values that were less than 0.05%, we were considered to be significant enough in the final model. So going to the results, we identified 25,188 index clients. Of these, they elicited about 54,235 partners. And of these partners, only 5,902, which accounts for 85.9%, came in were invited for testing. So you can basically see a substantial drop between partners that were elicited and those that were invited for testing, which could be explained by possibly the lack of confidence in bringing in partners for testing. And from the 85.9% that were invited for testing, only 90% came in for, only 90 were notified and successfully came in for testing. So of the 90 that came in for testing, provider referral and client referral kind of seemed to be neck to neck here with the referral approaches, with bringing in HIV, with bringing in partners of HIV index clients, whereby the client referral mechanism, we had about 34.6% partners come in for testing. And then with the provider referral, we had about 35.5% of partners coming in through the provider referral. And then followed by dual referral, whereby we have 7.7% of partners that came in through this referral mechanism. And then following by the family testing, network testing, and of course there's several that still have and that still were not documented, which mechanism they were referred to. And from these, we had several partners that tested for HIV from the provider referral arm, whereby referral arm accounts for 95.3%. Followed by the client referral arm, that accounts for 93.2% of all partners that were tested for HIV. And then of these partners that tested for HIV, 5.8% tested positive to HIV had been referred through the provider referral arm, and then 5.8% that tested positive were referred through the client referral arm. So no quite a difference between the provider referral arm and client referral arm. Looking at the basic characteristics of enrolled partners and index clients, So starting with the age of index clients, we can see that the majority of partners that were referred were referred by index clients that were aged between the age range of 35 to 44, followed by those that were between the age of 25 to 34 years old. And then going to referring to the index marital status, a number of index clients that were referred by index clients that had been married, followed by those that had followed by the single index clients. And briefly touching on the referral arm, I think I had mentioned this, whereby referral arm and provider referral arm take into most partners are referred through, are brought in for testing through these two referral arm approaches. And then employment status, we had about 53.9% of index clients being referring their partners, and about 43.7% of unemployed index clients referring their index clients. So basically, this also partner referral might also take into account people's employment status and education levels as well. The next variable that we analyzed as well was the gender, whereby male partners were more referred by 56.5% more than female partners, where they account for 43.4%. So going to the bivariate analysis, we had a few variables that were significant on the bivariate analysis, but we will highlight the most key variables, which are age. People between the age of 15 to 24, taking it whereby they are 1.6 times more likely to refer their partners more than any other age group, followed by the marital status, where we have divorced index clients or separated index clients referring more partners than the other marital age range. The other significant variable was also people that were paid for sex, whereby they were 1.67 times more likely to be referred by their partners than any other, than spouses or boyfriends or member of networks. So this is the analysis on the bivariate analysis. And then going to the multivariate analysis, we have also a number of variables that were significant. We had being widowed, being widowed was 1.4%, whereby people that index clients that were widowed were more like were 1.3 times more likely to notify their partners more than married index clients or single index clients. The type of referral approach, we had client referral bring in quite a number of partners, whereby 1.38 whereby partners that were referred through the client referral arm were 1.3 times more likely to come in for testing more than the provider referral or the dual referral or testing referral arm. And then Kigali City, of course, accounted also for quite a significance in the analysis, whereby we had 1.48 index clients come more likely to be referred for testing in Kigali than any other province. And then with regards to the relationship to index case, we had members of networks being 1.78 times more likely to be notified, to be successfully notified than any other people that had relationship with index clients. So what does this research show in comparison to the rest of the studies that have been conducted? Our analysis has shown that uptake of partner HIV index clients identified a high proportion of HIV persons. About 5.8% were referred through this, new index testing approach. And on average, 2.1 partners were elucidated. A substantial drop, we also noticed a substantial drop in partners identified and those that came in for testing, whereby spouses and steady partners were less likely to be notified, which is quite contrary to what other studies have found, given that most studies have shown that partners, steady partners and spouses are more likely to be notified, given the recall. The taking off the recall bias of the other members of the relationship to partners. The other finding that we noticed is there were improved outcomes with the referral arm. However, provider referral arm also seemed to yield quite an uptake of HIV testing among partners. Thank you very much. This is the end of the presentation.
Thank you, presenters, for all this presentation. So we are opening discussion. If you have any question and comment, any suggestion, please, yes?
Thank you for the presenters for the next presentations. My question goes to Joseph. Your results shows that 20% of women were not using family planning methods, which means around 80% are using family planning. But I haven't seen any proportion of those who are using modern and non-modern methods, or maybe I missed it. Do you have, how do you define a low uptake of modern contraceptive?
Okay.
Thank you, presenters. And me also, I have a question to the Joseph. I didn't have an analysis about accessibility of services. As you know, I work at Muhima Hospital. I know that there's somehow a problem of integration of family planning in that services, in HIV services, so that it could be better to know that the accessibility of services, so that you know that the services are available and they are not using it, and there are no problem of accessibility. Thank you.
Thank you for the comment, question. We come here to this table. Yes.
Thank you. I have a question for Angela. We're intrigued by if you could elaborate on the mechanics of the provider referral. How does it work? Does the client give the names to the provider, and then the provider makes contact with this contacts? And if that's the case, are you monitoring as well for gender-based violence? If you because I can assume if a patient, if a contact receives a call from a provider out of the blue, how does that work? My other question is for the first presenter. How affordable are contraceptives if you don't have insurance? Is it free? And how much does the insurance, if you have an insurance, pays for the contraceptives? Thank you.
Thank you. The next.
Okay, thank you for the good presentation. I have a question for Joseph. I would like to know among the 20% of HIV positive women that are not using contraceptive, what was the real unmet need? Because most of them may be on other method, or they may not, they may would like to have baby. What was the real unmet need among those women? And the question is to Angela. Thank you very, very, very nice presentation. Would you mind elaborating more? What was the elicitation proportion between the new identified PRHIV against those already on treatment? Thank you.
Thank you for the comment. Yes, go ahead.
Thank you very much to the presenters and for bringing us to these good presentations. So my question is to Angela. As we are elaborating more on the facts associated with this notification among the index cases, of course, this is talking more about the disclosure processes. So I would like to suggest, it's probably not a question but a comment or suggestion, if you could think about enriching this paper by probably adding some of the qualitative data, because most of these factors are more associated with individual perspective and self-stigma. So it would be better to enrich this by adding more of qualitative analysis to really clearly understand and associate this factor to the notification processes.
Okay, good. Can we start with maybe addressing this? Joseph, can you quickly address the 4 questions?
Thank you so much for the questions. The question talking about, asking about how to measure the lower uptake of contraceptive methods. Normally, the target is 100%. It means that all HIV positive women should use modern contraceptive methods or what you call dual protections. So if our study found that 20% of women were not using contraceptive methods, meaning that those who were using contraceptive method were about 80%. So the target is 100%. The question about the accessibility of the services was not assessed during our study for the question number 2. The question about someone who has health insurance influence a person to go to seek for health care services. So if we don't have health insurance, it kind of limitation to access services. On the question about unmet needs, also we didn't assess why those 20% were not using modern contraceptive, but as you know, we asked different questions. Maybe one of the reason of unmet need was around those findings especially side effects, and also wanting to have more children, because some women reported that they want to continue to give birth. So it's one of the unmet needs which leads to not uptake of modern contraceptives. Thank you.
Thank you for the comment. Now, Angela, you have like some comment and questions?
Yes. Thank you. Touching on the first question that asked to elaborate more on provider referral. So we have quite a number of referral mechanisms, but the three are most quite the key ones, whereby we have client referral, provider referral, and the dual referral. So the client referral is whereby an index client, a newly positive index patient volunteers to provide their partners, elicit their partners and offer them to come in for testing. So, and provider referral is whereby a healthcare provider, an index client agrees with the healthcare provider or consents with the healthcare provider to help them disclose their HIV status and bring in their partners for HIV testing. So provider referral is more done by healthcare providers, whereby they reach out to partners themselves and bring them partners for testing. And then the dual referral is whereby the partner, the index client, is in contract with healthcare providers to bring in their partners for testing. So pretty much they first agree to reach out to their partners for testing, but within a specific period of time, if this is not done, then healthcare providers help them out with the index, with bringing in their partners for testing. So the other question was about eliciting those that are partners that were already on ART. Unfortunately, we did not go further with the analysis to show this, but this is one of the variables that we intend to showcase in the coming days. It is one of the variables that are captured, but we were unable to show the findings of those that are on ART currently. So I think this platform provides some of the gaps that we also need to address going forward. I think those are the questions that were raised, and we take into consideration also Dr. Galika's suggestions to look into the qualitative analysis on the individual perspective. Thank you.
Yeah, thank you for addressing the comment. As you know, we have other participants online, and they have shared their comment and question. I'm inviting Omolo to summarize what we received from the online platform.
Thank you to those who are participating online. So there's a question to Angela. From your work, what's your sense of the registered female sex workers who we have in Rwanda? And maybe this can be answered by colleagues from the AP and surveillance unit in HIV, if maybe Angela doesn't have the information. The second one is on the MSMs that we have, I think, to get a sense of the proportions we expect in the index testing. And Dr. Menelas makes a comment about the co-infection challenge we have in HIV and TB, and raises the challenge of inability to do cultures for MTB and other organisms to identify other concurrent infections that affect the AIDS patients, and the challenges in running susceptibility testing. So thank you for that comment, Dr. Menelas. Maybe some responses from... Yes, Eric.
Thank you. Maybe we need to a study conducted in 2017 on female sex workers' estimates show that we have almost 13,000 female sex workers, and that's the estimate that we are still using. About MSM, we are now conducting a study to estimate their size, and results may be available next year. So if you look, I can also comment on one of the questions about the provider referral and the risk to GBV. I think for the provider referral, it's like an index to provide a contact to the provider, and the provider can contact the department. But before there is another screening question asking if there's no, the partner doesn't have any risk on violence. So then this is to limit or to reduce the risk of violence. So about HIV and TB, I think we don't have any study on this, but we estimate around 5% of co-infections. Thank you.
So one last question behind there, and I think we should... Albert, if you can make it short.
Thank you. Don't be too long. Thank you to the presenters. I have just like one question to Musesa. I hear that there is a strategy to treat all HIV-infected people in Rwanda. Now, from the presentation, I saw that not all HIV people are in reality. How come does that happen in Rwanda? And also, they are not on control mixers of prophylactic treatment against opportunistic infections. How come that happened in Rwanda to have that strategy to treat all? And I also saw that we know that there is the observed treatment by community workers and the strategy to ensure the adherence to TB treatment in Rwanda now, and I assume it does work very well. But I also saw that not all of them are followed up by community workers. What are the reasons behind? Thank you. Maybe someone even for the program can just update us on that.
Yes, David, can go ahead.
Yeah, thank you. I think the possible explanation for TB/HIV patients a small percentage not on ART. I think, yes, you say it should be treat all, but some are not on ART. I think it's because, if a TB person, a TB patient is also diagnosed to have HIV, there is a priority to first treat TB for some weeks and then start ART. So we think those who are responsible, I mean the clinicians, they record in the reports that they are not on ART, but when they start the ART, they don't go back and update the records. So we think that is, but it should be treated, and we think that that's how it is. But when they start TB treatment, they put in the records that they are not on ART, and yes, it is. But when they start the ART weeks after, I think they don't go back and they record that they are now on ART. So it's an issue we want to go back and verify if it is that, if it is the reason. And the other question about, yes, community health workers help in the follow-up of people, of TB patients, but not all are followed by community health workers. I think that maybe I will request Dr. Patrick, the DM, to also comment on this, but all TB patients are not followed by community health workers. It's a good percentage is followed, but not all TB patients. Thank you.
Okay, thank you so much, Edward. Thank you, Joseph and Angela. I think if there is no other comment, I think we need to, oops, okay. That's there.
Okay, thank you. Normally there are two reasons people should not start IFT, because, you know, the diagnostic of HIV should be using the routine channel, or we have also the people who are newly diagnosed when they come with TB symptoms. Because we are testing all people with presumptive TB, we may find that the newly people who are HIV. And among them, it depends on their clinical status. Some of them can start after 2 weeks, other between 2 to 8 weeks, depending on the clinical status. Maybe we should check in the database if the 60 people who didn't start the ART, their outcome, probably the majority of them may die before the 8 weeks, because we have high death rate among co-infected, specifically within the 2 first months of treatment. That should be probably the reason. And about community health worker, normally all TB patients are not followed by community health workers. It depends on the patient, because it's we ask to the patient if he wants to be followed by community health workers. Once the patient agrees, then we communicate to the community health workers, and then we sign the agreement with the community health workers. But around 58% of our TB patients are followed by community health workers. But it's not a requirement. It depends on the wish of the patient. Thank you.
Thank you so much, Dr. Patrick. Dr. Patrick had to have the last word on that discussion on TB. He's a program manager for the TB division. And so at this point, we want to thank you for the time, for the discussions, for the presenters. Thank you. You can go back. And for the sake of time, obviously there's a lot to talk about, and I think it's been a very exciting discussion. I want to thank also Dr. Gallican for sharing the highlights about the progress and the priorities and the gaps we still need to fill. And we see from the presentations that some of them are already looking at these areas, the co-infections, the chronic illnesses amidst our aging HIV population, the gaps in the first 95, and issues around higher incidence in and the gender disparities and the finding men and so on. So I think there's a lot to talk about, and we want to appreciate the conversation and also note that there's a lot of improvements and work that also some of the trainees will need to work on the presentations, on the contents of their work as they move them to the next level. And I think it's been very enriching to get your insight. So at this point, we are running late and we are sorry about that, but we have a very exciting session coming up next. We have a keynote on other public health priorities that will be given by Dr. Albert. I see he's already here, but I know we're getting tired, and so we'll take a 15-minute coffee break at this point and convene. If you can make it 15 minutes, we can try to recoup some of the time. So thank you so much for your participation this morning. So we'll be back in 15 minutes.
Alo, abantu batarazana aho turi dumisiyo ngo muzijyane iriya. Abantu bavuye mu ntara muzane ordre de mission kuri desk. Muze kureba uyu mudamu Diane.
Okay, so I think we can get started again. So for the interest of time, we are going to try to make it as quick as possible because I think we are a little bit behind. So we're going to make it as fast as possible. So welcome again. Welcome you to the plenary session number 4. We also like to welcome our audience that is following us online and through other social media or virtual platforms. So for this session, we are going to kick it off with a keynote speech, and our keynote speaker is Dr. Tuyishime Albert, who is from the Ministry of Health, Rwanda Biomedical Center. Dr. Tuyishime is the head of the HIV Disease Prevention and Control Department. Dr. Tuyishime is going to talk to us about other public health issues. So we welcome Dr. Tuyishime to give us your keynote speech.
Thank you very much, Dr. Vincent, for the introduction. It's really a pleasure for me to have this opportunity to give a few remarks on the other public health issues. But today, we wanted to focus more on maternal and child health program highlights, so that we can give a bit of context for the next sessions with the oral presentation. So without further ado, I want to take you through some of the highlights from the MCCH program here in Rwanda. And some of the data we are going to share with you, they are from the last fiscal year, the fiscal year 2020-2021. Here we want to share with you the current status about the antenatal care coverages we have in Rwanda. We also try to compare the fiscal year 2019-2020 and the last fiscal year. So if you look at the first antenatal care, you can see an increase of around 8%, which is good, but we still have a long way to go. And if you look at the fourth antenatal care standard visit, we also registered an increase of 6%, but you can see we are still below 50% among the pregnant women we're expecting for the fourth antenatal care visit. Here we are trying to look across districts. The bar in blue is the first antenatal care visit in the first trimester, and in the red is the fourth. You can see the first standard visit across districts. It is ranging from 7% in Gakenke district down to 34% in Kamonyi district. And for the fourth standard visit, it is varying between 62 in Kayonza district and 28% in Kirehe district. If you look closely, you can see, for example, in Kicukiro, one of the districts we have in the city of Kigali, you can see we have more 4 antenatal care standard visit than the first one. But this is most probably because of pregnant women coming from other districts for the following visits in the city of Kigali. And also, if you zoom in Kicukiro district, we are having in many private clinics providing antenatal care services. In terms of deliveries, we wanted to share with you the facility-based deliveries. At national level, we had an average of 85%. But again, you can see Nyarugenge district with above 100%, with the same reasons as I said before. And still Kamonyi is coming 57%. So if you take the two slides together, health facility-based deliveries and antenatal care, you can see there are similarities. But also, we would like to have some of the FETP detectives to help us understand more why we are having this situation in those two extremities. Here I wanted to share with you some findings from the latest Rwanda DHS conducted 2019-2020, where we had a slight decrease in terms of maternal mortality ratio from 210 to 203. If you compare that decrease with the two previous Rwanda DHS, we registered a less decrease compared to what we used to have. And why? Those are the questions we want to understand more, but also we all know that the last mile is always the hardest. Zooming into causes of maternal mortality, looking at the confidential inquiry into maternal death conducted last year in 2020, we observed or we noticed that 38% of the maternal death they are due to obstetric hemorrhage, and 23% they are due to unanticipated complications of management. The two portions or causes, they are taking more than 50%. They are causing more than 50% of maternal death. And both of them, we believe we can do better, or we can prevent some of them and save some lives in that portion. After delivery, we have the postnatal care for both the mother and the child. For the mother, we have 4 postnatal care visits as per the current guidelines, and we have also 4 for the baby. Across the 2 or the 4 postnatal care consultations or services, you can see we are still having that dropout. Why? There are different reasons, but also we need to support them with evidences. So you can see for the mother, the postnatal care consultation 1, which is actually conducted at the health facility, we are at 91%, but if you look at the postnatal care 4th visit, we are only having 62% of the mothers visited or followed. For the baby, we come from 92% for the postnatal care, the first one, up to 62% on the postnatal care visit 4. Talking about neonatal morbidity and mortality, again, here we are looking at the data from the last fiscal year, 2020-2021. Starting with the morbidity, you can see neonatal infections, they are causing 59%, they are responsible for 59% of the hospitalized cases, followed by prematurity at 23%. In terms of mortality, again, the prematurity comes in the first place, followed by the asphyxia, and then neonatal infections. In terms of neonatal case fatality rate, congenital malformation, they are killing many babies. For the perinatal mortality, the national average for last fiscal year, we had 26, whereas we registered the highest mortality rate in Huye. Again, there we have an assumption, or we think this is because in Huye we are having there a referral hospital that might be receiving many babies in critical care, and Burera with the lowest mortality rate of 16. Talking about under 5 years, we are sharing their top causes of consultations, where respiratory diseases, they are coming in the first place, followed by diarrhea, pneumonia, and in the last place we are having severe anemia. But again, if you look at the top 5, they are also preventable or treatable if they are really diagnosed on time and the right treatment is provided in the right conditions. For the mortality in the same age range, under 5, if you look at the data from the last fiscal year, we have bone and joint problems coming in the front, followed by respiratory diseases, and then sepsis. Putting the 3 main indicators on the same graph, you can see the decrease we've been registering in under 5 mortality, which is almost the same as infant mortality, and the same as neonatal mortality. But you can see the graph is being, if you can say, flat. So we also have to understand why we are not still registering the same decline. What are the reasons? What are we missing? Who are we missing? What can we do in the best way so that we can keep the same trend until we reach the SDGs, or if we can do until we have 0 lives lost. We've been discussing about family planning in the context of HIV, but here we want to give the broader status, where we are sharing the percentage of women of reproductive age who are current users of contraceptive methods. Here we are combining traditional and modern methods, and it's always good to have figures disaggregated by district so that we can be able to target our interventions. So you can see Huye district is coming at the first place with 67%, and Rusizi coming last, 33%. Postpartum family planning method, as the newest method that we introduced, we wanted also to have it presented on a separate slide. But you can see we are really having Gicumbi championing or coming in the front with 85%. And again, Rusizi coming the last 20%. One of the channels used when we are providing family planning methods, we are using community health workers on top of health facilities, but also we are having community health workers following clients that have been initiated on family planning methods from the facility. So we also encourage family planning clients to get in touch with the nearest community health workers so that they can have the service at the community level, but also trying to improve on the adherence on the family planning. So you can see Gakenke is on top with more family planning clients followed by community health workers, and Nyanza coming with the fewer clients followed by community health workers. Here I wanted to plot and compare different Rwanda DHS we've been having. So you can see we had a consistent increase, but also one of the questions we always get when we are discussing on this slide is what is the end point? How far do you want to increase until? So that one, I'm throwing it to you so that you can give us your comments or your thoughts on that. Because you can't say we have to go until 100%, 95%, 98%. So it's subject to debates or to discussion. This is the vaccination status, which has been consistently above 90% for all the antigens we are providing in our expanded immunization program. For the growth monitoring, which is one of the strategies we are implementing to help us fight against malnutrition, we have regular monitoring of growth done by community health workers, and as of today, they are doing monitoring of weight for age. So you can see in Rubavu district, we are having many children benefiting from the growth monitoring, whereas in Kamunyi, we still have work to do. Even if all the districts, they are really above 60% of the eligible children who are benefiting from the growth monitoring. So what are the challenges we are having in the implementation of different interventions that we are implementing in order to have those achievements or those levels of success? One is linked to human resources, especially in remote areas. But also, this is linked to a high turnover of trained staff. In the maternal and child health program, it's one of the programs that needs consistent capacity building because of the adjustment in interventions, but also based on new evidences we are having as we're implementing. Secondly, we are having a challenge around a model for training and mentorship for health centers. At district level, we have more or less a well-designed, implemented, and followed model of training and mentorship, which is not the case at the health center level. So it varies from one district to another, depending on the expertise available at the district hospitals, but also on the approach used there. Thirdly, especially during this pandemic, COVID-19 pandemic, we experienced some delays in shipments, especially for family planning commodities, namely Implano and Microgino. And this was a global challenge, but we felt it really on field. Lastly, we have also a challenge around community health services. We've been designing the package of services provided by community health workers, and based on the demand from the community, we kept increasing the package, and at the end we had some challenges around the continuity and sustainability of this program. And specifically during COVID-19 pandemic, we had to make special consideration for community health workers, for them to be able and continue provide the services, whereby personal protective equipment were needed for them to be protected and be able to provide the services. And this was really key to ensure the continuity of essential services. What are the innovations we are having? So we try to go digital, if I can say, whereby maternal morbidity and mortality weekly reporting have been integrated into the HIS2, Health Management Information System. We are working on community health workers, multidisciplinary model, whereby we are shifting from specialized community health worker to a polyvalent community health worker. We are initiating a new learning of community health package for community health worker supervisors. We are introducing community health mentorship approach that is going to supplement or complement the e-learning approach, but also facilitate the implementation of the polyvalent model we are introducing. And lastly, we wanted to recognize that the work that is being done by community health workers is really appreciated by the communities, the population of Rwanda, and some best practices have been really recorded during this COVID-19 pandemic period, namely screening, psychological support, surveillance, sensitization, referral, and reporting. And one of the key elements we got from this program from the community health workers has really allowed us to ensure the continuity of essential health services. Thank you very much for your kind attention. Your thoughts, comments, or questions are welcome. Thank you.
So thank you so much, Dr. Tuishime, for the keynote speech. So we're going to take the next few minutes to take your questions, your comments, your clarifications. So if this part is open, just raise your hand if you want, okay? So please, just before you ask your question, state your name and your institution so we know who you are. And then also try to make it as short as possible so that we keep this session short. So we will collect the questions and then we'll have them answered at a go. Please go ahead.
Okay, thank you so much for this opportunity. I'm called Similian Dajimana, Data Manager, Kabwe District Hospital. I have some questions. I have seen in the presentation, which is good from Tuishime. My question is that I have seen some percentage with the coverage of INC, which is a registration which is above 100%. I would like to know the denominator that you have used. The question B, some indicator in the MCH, they have many denominators. For instance, there are some health facilities which has using the neurologist BCG as denominator, and the others using different denominators, as you know it. So I would like to know what's the best denominator that should be used so that we don't bias our data. So the next question is about the different program in the RBC and the MOH. I would like to know why there is no real data, the current data on the website. If you want to know some situation of the some disease, you can't find the current one. Why there is some kind of privacy in the data produced at national level. So this is my last question, is that some question is about the PF coverage and the delivery at a health facility. I would like to know if there is some relationships. Since some says that once the PF increasing, the delivery should decrease. Is there any relationship? Thank you so much.
So thank you for your question. We'll take another question from the audience. Please be reminded to just keep it to a question or two, so that we can gain an opportunity to others to ask. Please go ahead.
Thank you very much. I thank the presenter for a good presentation, very informative. I'm Stella Matutina Omohoza. I work at the School of Public Health, University of Rwanda. I have two questions. The first one is, you have said that we are trying to go digital, and you mentioned several information systems you have at the RIBC, where you try to collect data on a daily basis. You mentioned DHIS2, and we know also there are AMR. So I want to know the status of having an interoperable system. How far are you in terms of making sure that we minimize the reporting burden of service providers? The second one is a question of curiosity. In your presentation, you mentioned that Kamonyi district has low indicators. So what are possible reasons why for Kamonyi do we have we tried to investigate the reason why Kamonyi continuously has low indicators? Thank you.
Thank you for your question. We'll take one more.
Thank you very much for the good presentation, and I thank Dr. Albert for this informative presentation. My question is to ask whether there is a plan to undertake an investigation of factors which could be underlying the low rate of 4 ANC and 4 PLC. As you know, WHO now is suggesting 8 visits, meaning at least 1 visit per month. So if you are still having 41%, it will be difficult to reach the 8 visit. And another issue is, do we have a system for conducting operational research to evaluate the interventions and adjust as needed? This could apply for low decrease that was observed. This low decrease in maternal mortality, which was evidenced by DIHS2, we may need to see whether the interventions that have been established are working or not. So it will allow the program to adjust in the pathway of implementing this to see how we can evaluate the effectiveness of the interventions and adjust in the midway of the strategic planning. Thank you. Over.
Thank you for your question, Dr. Rosette. I think now we'll send it back to Dr. Albert. The floor is yours.
Yeah. So, thank you very much for the great questions. If I start with the first question from Ndagijimana about the denominators, new registration. So we use the numbers we are getting from the census, the last census, and then the projection until 2021. So it is the best estimate we can use up to now, but as we are maybe this year or next year, we are going to have the new census that is going to give us the updated figures we have to use. For different denominators, you mentioned BCG, but also some use facility-based deliveries. That's true. And what we are doing to address this, we cannot say this is the best one, because whoever is using one of them has supporting arguments. And the best way to address that is to have in place a system that is going to help us having the same figures denominator. And this is going to come from the CRVS, Civil Registration Vital Statistics. We all know we've started implementing this system at facility where every birth is registered, immediately reported or recorded in HMIS, as well as in the national registry. So from there, we are going to be able to have the same denominator. And remember, we are also going to have, on top of this, the verbal autopsy. That is going to help us capturing the death we are having at community level. So the two elements, they are going to help us having the same denominator. For the website or updated statistics, if you are not sharing that, it's a gap we have to address. But the plan for us, or the aim for us, is to make sure the statistics or updated information is accessible to anyone, being on our website or the Ministry of Health website, or from the program reports we are producing at the end of each fiscal year. So we take it as a positive feedback, and we are going to make sure they are available to anyone. And I'm happy most of the program managers are here, so immediately we are going to look into that and say malaria, we don't have updated info available, or TB or epidemics, and we address. For the family planning coverage versus deliveries, it's a discussion. We are talking about different cohorts. If we have a woman having as a client for the family planning, remember we're having also a new mother, if I can call her a new mother, who is entering the childbirth period. So we are talking about different cohorts, but we can discuss, and we are open to have your feedback on that. But I don't know if we have, maybe I will throw it back to Matutina. From the research perspective, do we have some evidences saying that if you have an increase in family planning of 10%, you should be expecting 5% decrease in deliveries? So let's discuss this and see if it is really evidence-based. I'm avoiding to give flat confirmations or response. On the question of interoperable system, you are right, and it's an ongoing effort. Last week we even had a session here with different actors discussing on the interoperability of the systems, not only within the health sector, but also with the systems out of the health sector. So it's a top priority for the country, and especially for the sector. And Tom can confirm that. Why Kamonyi with the low coverage and uptake? We are having a deep investigation to try and understand why we're having this situation in Kamonyi district. So as soon as we have findings, the first step will be to try and address the root causes so that we can have the district catching up and being at the same level as other districts. From Dr. Rosette, on investigative, I missed that one, but I can start with the second one. Do we have? Yeah. Mm. Yes. For the low coverage, we are having an ongoing investigation effort that is going to be concluded in the next 2 to 3 months. And this is going to help us having the root causes, and then we'll work together and see how we can address those causes. On the operational research, we do have this, and we have already conducted several in the nutrition area, but also in the interventions linked to maternal and child health, especially facility-based ones. We are having some efforts or some ongoing operational research. But since most of us are part of the technical working groups, the various technical working groups, this is one of the areas we are expecting different experts to help us and contribute to have really impactful interventions being implemented. But I totally agree this is an area that is really needed. Thank you.
Okay.
So thank you so much, Dr. Albert. I think in the interest of time, we're going to move on to our next session, but just before we do that, I would like to request for a round of applause. Thank you, Dr. Albert. So I'll pass it on to my colleague, Dr. Maria May, who will moderate the next session.
Thank you, Dr. Vincent. Our next presenter is Hagabimana Aphrodis. Aphrodis is a graduate from cohort 5, and he's working currently at Kigeme District Hospital, and he's going to present on risk factors associated with stillbirth in Kigeme District.
Hello, everyone. Thank you for your time. My name is Aphrodis Hagabimana. Welcome to my presentation. Risk factors associated with stillbirth in Kigeme District Hospital. So this outlines stillbirth, as you know, is to remain a global public health issue, as well as social and economic development. Where in 2015, globally, there were approximately 2.6 million stillbirths recorded, where the majority of them were reported in low and middle income countries. So the target of Sustainable Development Goal is to reach or to get at minimum of less than 12 stillbirth rate per 1,000 births in each country by 2030. During this study period, where we collected data in 2018 and 2019, the stillbirth rate in Kigeme District was at 27 per 1,000 births. So the reason why the aim goal of this study was to determine the associated risk factors. We used a cross-section study where one cases were matched with 4 controls. The cases was defined as infant death at least 28 weeks of pregnancy or during delivery with 1 kilogram at weight. So Kigeme District Hospital is one of 2 districts of Nyamagabe District, where in this study period, we have recorded 121 stillbirths among more than 4,000 deliveries babies. So all cases were taken in that period of time, where 2 cases, so 2 controls were considered, recorded before the cases, and 2 controls were recorded after the cases were taken in the maternity registers. So the end, we end up with a total of 605 participants used in this study. Data was collected in registers by trained nurses and midwives, where they collected information related to social demographics, gynecologic and obstetric pattern, mother and medical history, and newborns baby information. So logistic regression was used, and the questionnaires was developed in APM47, and data were analyzed in Stata version 16. Ethical consideration or permission was obtained where study were conducted. So for the result, among of 605 files reviewed, the majorities of mother were aged between 21 to 34 years, where the majority of them were attended at least primary education level. The mothers who attended greater than 4 antenatal care visits were more at 72%, while mothers delivered at Kigeme District Hospital, the majorities were delivered through normal vaginal delivery. And the majority of mothers didn't present labor complication during delivery period. So for medical history for mothers, for those file reviewed, the majority of mothers didn't present any hemorrhage during her pregnancy period, the same as they were tested negative to malaria at 89%. So for the newborn informations, the majority of babies were born with greater than 2.5 kilograms at 83%, where the majority of babies were female. So in analyzing the associated risk factors, we have found that the mothers who attended less antenatal care visits were 1.84 times more likely to have stillbirth. The same as those who delivered through assisted delivery, vaginal, they were 1.83 times more likely to have stillbirth. While mothers delivered through cesarean section were around 18, less likely to develop stillbirth. And babies who delivered through with weight less than 2.5 kilograms were 5.6 more likely to die through stillbirth. So by conclusion, in this study, we found that the associated risk factors, they were less to attend for antenatal care visits, vaginal assisted delivery, hemorrhage, and labor complications, and low birth weight. So we should recommend more education campaigns to the mothers to attend antenatal care visit, the same as Dr. Bell said, more mentorship are needed in the hospital settings to ensure that assisted delivery are flowed well. The same as cesarean section should be encouraged, especially for the woman who had presenting abdominal presentation of complication, and proper action can be taken to decrease the low birth among the mothers through education given in the antenatal care visit. So those are our acknowledgements. Thank you for your time.
Thank you, Aphrodis. The following presenter is Zabulon Mutawazi. Zabulon is a nutritionist working at Nyanza district. He's a graduate from cohort 4, and he's going to present on factors associated with stunting among children in Nyanza district.
Good afternoon. pleased to present to you my work on factors associated with stunting among children aged with 6 to 33 months in Nyanza district. The research has been conducted in Nyanza. As you see, the prevalence of stunting on the map, you see that the developing countries are more affected by stunting. Among them, Rwanda also is affected by stunting. As you know, Rwanda has not achieved the Millennium Development Goal to decrease stunting. Nyanza, where this study has been conducted, also have the problem of stunting. Some nutrition intervention have been implemented countrywide to decrease malnutrition and stunting. But still now, stunting is a problem to children under 5, mostly children under 2 years. This study has been conducted with the objective to calculate the prevalence rate of stunting among children under aged between 6 and 23 months in Nyanza district, and also to identify associated factors with stunting in Nyanza district. So, as I said, the study has been conducted in Nyanza district, where we conducted a cross-section study. The sample size has been calculated using the proportion of stunting. The sample size was 374. This is the study variables we used, where we categorized the independent variable in socioeconomic and the demographic factors, child health and caring practices, and environmental factors. Those are details of variables that we used to find out if they was associated with stunting. Methods, data have been collected in the villages. After receiving data, we entered the data in a PM4 to calculate the score of health for age, and the analysis has been used using SPSS, and we used univariate analysis to calculate proportion, and logistic regression to find association between independent variable and dependent variable, which was stunting. The result that we found that among children between 6 and 23 months, 28.1 was stunted. Other findings: exclusive breastfeeding up to 6 months, 9.9% did not receive exclusive breastfeeding. And about complementary feeding, only 62.6 were received complementary feeding at the age recommended, at 6 months. Children who receive minimum meal frequency, 67% only receive the minimum frequency recommended. About minimum dietary diversity, only 1/3 received minimum dietary diversity. Factors associated with stunting. We found that the level of education of mother was associated with stunting, and family of the category 1 and 2 also were associated with stunting. As conclusion, stunting remains a public health problem in Nyanza district, as the result showed that 28.1% of stunting is still a public health problem because it is still high at the percentage recommended by WHO to have stunting less than 20%. Only 1 on 3 children receive minimum meal dietary diversity. Stunting factors that we found out are contributing to stunting was the low education level of the mothers and the low socioeconomic status. Recommendation: recommend to healthcare providers to increase social behavior change of mothers in nutrition, especially breastfeeding and complementary feeding. We recommend to district leaders to improve economic status of poor population and increase the availability of diversity of food, where I found that in the meal of many children were missing fresh food, eggs, and fruit. Those are recommendations we give, and we thank all partners involved in this research, and thank you for your kind attention. Thank you.
Thank you, Zabulon. And our last presenter for this plenary session is Adeo Sanzuhoro. Adeo is currently working at Kiwungo Hospital, and he's a graduate from cohort 5. He's going to present on prevalence and risk factors of hepatitis B and C virus infections among people screened in Ngoma district.
Thank you once again. This session is about hepatitis B and C, a study conducted to investigate the prevalence and risk factors associated with hepatitis B and C in Ngoma district. As a background, hepatitis, as all of you know, is a major problem of public health, and also has potential risk of causing chronic disease leading to liver cirrhosis, cancer, and death. And WHO reports show that they cause over to 1.3 million deaths per year, more than HIV and malaria. And the study conducted in Rwanda countrywide estimated prevalence of hepatitis B and C respectively to be 3.9 and 6.8. Objective of this study was to determine the prevalence and the risk factors associated with hepatitis B and C among people living in Ngoma district, and data set was collected in 2019. Method, this was a cross-sectional retrospective study, and we used the secondary data collected during hepatitis B and C screening campaign conducted in Ngoma district in September 2019, and the population all people who attended screening. Data set used were accessed from Kiwungo for hospital. Yes, and analysis descriptive bivariate and multivariate logistic regression. The results, the total participants in this analysis were 6,169. Female were 71%, the majority. And the median age of participants were 41 years. Range of participant ages from 15 to 96. 53.8% of participants were married. The prevalence of hepatitis B surface antigen seroprevalence were 23.3, while hepatitis C antibodies seroprevalence were 4.3. Among the participants, these were comorbidities registered during that data collection and the screening campaign. As you can see, liver diseases and the viral hepatitis in the family were the most prevailing comorbidities. Behavioral risk factors among the participants. The participants who were surgically operated were 7.8, and the participants who received the blood transfusion were 4.4. Who reported to be physically traumatized physical injury 5.2, and traditional scarification 13.9, multiple sexual partners 3.7. People who are not vaccinated, where the majority, 51%, were not vaccinated for hepatitis B. Factors which were associated with hepatitis B included being male sex. The male participants were 2.1 times more likely to get hepatitis B than a counterpart female. And also participants with a history of liver disease. This can indicate that there could be horizontal transmission and a traditional operated or scarification, and the people who were not vaccinated for hepatitis B. Risk factors or factors which were associated with hepatitis C included advanced age. As you can see, age above 40s, and having the people who were having cardiovascular diseases also are most likely, and the history of liver disease, as in hepatitis B, and the viral hepatitis family. As conclusion, this prevalence of hepatitis B, as according to the classification, was in an intermediate endemicity, and also hepatitis C was high compared to global prevalence, which is 2.5. And also both to hepatitis B and C prevalence were low compared to similar studies conducted in Rwanda. Recommendations, we do recommend to continue regular screening activities to find out more cases, increase the number of people who are vaccinated for hepatitis B, and sensitize the population to change the custom of traditional skin injuring practices. And also avoid sharing personal contaminating items, as we saw in both hepatitis B and C, both in history in the family and the history of personal hepatitis, liver disease, were associated with having these diseases. Thank you for your kind attention to this presentation.
So thank you very much to our presenters. So we are moving on to the section where we'll take questions from the audience. I think I see a hand behind there. So once again, just before you give your question, state your name and your institution so that we know who you are. Okay, so we have one question there. And then also, please indicate to whom your question is directed to.
Thank you very much. I'm called Metusela Habimana, currently working at Rwanda Hospital. My question is addressed to Zabilo for his presentation. Among the factors associated with stunting was found to be the category, with the category, the poor people are more affected, poorest. However, the government, it is a long time since it has given a lot of intervention to the poor. Yet, the stunting is still a problem among the poorest community. And I would like to ask if the authority of Nyanza district are aware of those findings, and if there are any action that has been taken after observing these findings. Thank you.
So thank you for your questions. We are going to pick the questions, then we will answer them. Any other questions? Please, just by show of your hand so that we can bring the mic to you.
Thank you. My name is Alexis. I'm a doctor working at Gisenyi Hospital. I have a question for Aphrodis. So, Aphrodis, you said that during your study you found cesarean deliveries to be protective, but you also found that labor complications predisposed to stillbirths. Yet we know that cesarean deliveries, most of them, especially emergency cesareans, are done for labor complications. My question is, what were the labor complications of interest? I assume they are the ones that didn't lead to cesarean deliveries. Thank you.
Thank you, Doctor, for your question. We will get one or two more. Yes, we have a question over that side.
Thank you for this opportunity once again. Simirian Dejimana from Kabuga District Hospital. My question is addressed to Zabulon. I would like to ask if has cross-checked his result with the result from Cisco. Is there any relationship about your findings and the data from Cisco? If there is a relationship, there is no relationship, what do you think as a cause of that difference? That is my question. Thank you.
Thank you so much. Do we have space for one last question? So I don't, unless I am not seeing you, I don't see any other hand up. Oh, we have.
My name is Igras Kawanyana. I'm asking the question of stillbirth. Do you know that there are two kinds of stillbirth? You know that there are a fresh and emaciated stillbirth. And those stillbirths, for handling them or preventing the stillbirth, the interventions are different. Do you think that you can differentiate that so that you can read the health facility to handle that or preventing it, and even in the community level? Thank you.
So thank you so much for your question. I think we are going to give an opportunity to our presenters. I think Zabulon has two questions for this one, and I think there's a question on stillbirth. So we are going to open this opportunity to for you presenters to give your responses. So we'll start with Zabulon.
About the first question, if the district leaders are aware about the result of my research and the intervention to act on the population with low socioeconomic, where the population of the 1 and the category 2. I can say yes, because with the routine data also, we have a different meeting with our leaders at district level and in planning of district plan to eliminate malnutrition. My findings was used to plan activities to help or to help population with the population of high risk of malnutrition. Among them, there is those population of the category 1 and the category 2. About the second question, if there is similarity of my funding, the findings of my research and the data of SysCom, there is a different. In SysCom, the target population where we can find the result of stunting is the children of age of 3 months to 18 months. But our research, the target population was 6 to 23 months. I can say that the result could not be similar, but again, what I can say, the prevalence rate of stunting was high according to the results of the research, comparing to the data of SysCom. Thank you.
Thank you, Dr. Alexis, for a good question. This study, as you have seen, C-section was one factor which is protective. As I have said, you plan a C-section because you have observing some normal complication or a woman presenting some normal condition. So it is recommended, it is better to, you can encourage to use C-section instead of using assisted delivery, because it is where you can save a woman early. As you have said, those labor complications you have already identified. So it is better to make rapid surfaces or operation to C-section more than waiting until you used assisted vaginal delivery. As you have seen, it is associated to stillbirth. For the second question of Kawates grass, all two types of stillbirth, muscle flesh, were considered because we have taken the cases as a stillbirth to any death at least 28 weeks or during pregnancy, but we have defined it at a baby born with 1 kilogram as our limit of study of defining our cases. Thank you very much.
Okay, so thank you very much to our presenters. Just I know that we have not exhausted all the questions. I'm speaking for the session since the morning. I know we have had several speakers. We didn't have the time to take all your questions. You can continue to interact with the speakers during the break. You can take an email and email them after, so that we continue this, we keep this discussion going on. So just before I release the presenters, I would like again to ask for a round of applause for our presenters. And just before we break off, I would like to make a number of announcements. So we have a small change in our agenda. So we want to combine the lunch session with a poster session. So once you've quickly had your lunch, we will then invite you to the poster session. That is, the poster boards are outside the room on this other side. So do not miss that opportunity. We have very exciting posters on TB, on HIV, maternal and child health, and a number of other subjects that people have worked on in the parts that the different parts. Anyway, the posters are out there. Do not miss that opportunity. So have your lunch, and then once you're done, please come, and then we can start our poster viewing session. Then we will reconvene here at 3 o'clock. I know we are running a little bit late, but if we have a quick lunch, then we can try to catch up. And then in the afternoon is when we will have our award ceremony, our award presentation ceremony, and then we'll have our guest of honor to give a closing remarks, and then we will close the conference. So I hope I haven't forgotten any. Oh yes, I do have another in-house announcement. I'm going to give it in Kinyarwanda. So abantu bose bavuye mu ntara batanze ordre de mission zabo. Mission ziratangwa nyuma ya saa sita. So don't leave before that. Abanyakigali namwe murahabwa transport. So with that, again, I'd like to thank you for your presence this morning, and then bon appetit. Hope to see all of you at 3 p.m. where we move towards the closing ceremonies. So thank you again. Oh, the lunch? Well, I would expect that the lunch is where it was yesterday. So in the two sections. So thank you and bon appetit.
strengthen the epidemiologic and laboratory management capacity of Rwanda to meet the challenges of the current, emerging and re-emerging infectious diseases and other public health problems.
The program is well designed to train nurses, doctors, veterinarians using the learning by doing approach. Since the inception of the program, they have been involved in different series of action before, during, and after every outbreak recorded in the country.
More than 10 years later, it's obvious that the program has lived up to its expectations. The graduates of the program, who we also sometimes call disease detectives, have increasingly assumed more and more responsibilities of technical and public health value to the country.
In March 2020, Rwanda reported its first case of COVID-19. Quickly, it was understood that COVID-19 was deadly and its capacity of spreading was like no other disease the country had faced before. It was without a doubt that to manage the situation successfully, a level of expertise from the Epidemiology Task Force was required to respond with effectiveness.
Coming to the COVID pandemic that we are experiencing today, as an SLT, I was able to be part of the team that started points of entry surveillance at the airport at the beginning of the outbreak. And I was also able to lead the contact tracing and investigation teams as well. I really credit my professional experience to the SLT program. This is because prior to joining the SLT program, there's so much that I didn't know, including analyzing data, responding to outbreaks, and being able to be really boots on the ground, listen to communities and what the population has to say, and translate that into decision making.
The purpose at the end is to have someone at the district level or at any level within the Ministry of Health, someone who is capable of analyzing data and be able to provide a conclusion and recommendation so to control or to prevent diseases.
This is where FETP took command and discharged staff, trainees and alumni on the field so that they can apply their expertise in outbreak detection and response to mitigate the spread of COVID-19 in all the districts of Rwanda. The ongoing success of FETP's training programs has fostered mutually beneficial relationships with Ministries of Health, RBC, and other key partners like the University of Rwanda and CDC.
So I have contributed to the training of the Fetp frontline, both by supporting the training of trainers, so that we can have a good number of people that we support to train people from districts. And I have also supported the mentorship of the staff from the district.
The opportunity that I had to be part of this program over the years has been actually a program that is quite life-changing in terms of career choices, career paths, the work that you do, and of course the impact that you make eventually to the community.
During my journey as FLTP resident and a graduate, the acquired skills have contributed to the improvement of the performance of the epidemic surveillance and response division in terms of data quality, early detection, and effective response to outbreaks such as cholera, measles, shigellosis, typhoid fever, to mention a few. Personally, FLTP has contributed to my career path as a field epidemiologist and helped me to grow professionally.
So, very good afternoon to everyone. A good afternoon to those at the back. I see we have a separate conference there. I think it's a breakaway So, in the interest of catching up with time, I know we're a little bit late, but we are moving towards a very exciting part of the conference as we wind it down, because we finished this afternoon. I would like once again to request for your attention as we start the activities for this afternoon. So, as per our agenda, we have some planned activities, but just before that, I would like to take this opportunity to invite the Rwandan resident advisor, Dr. Jared Omolo, to give us a brief summary of the conference that has happened in the past 2 days. Welcome, Dr. Jared.
Thank you so much, Vincent. Our guests, participants, all protocols observed. I just thought we thought to give you a brief summary of what has occurred for the last 2 days, and just to reflect on what we achieved. So we did have 92 abstract submissions for this conference. So the scientific committee selected the top 62 of those abstracts, 21 of them as oral presentations, and the rest as poster presentations in different thematic areas. So the abstracts were submitted by trainees and graduates from the 4th, 5th, and 6th cohort of the FETP training program. The 6th cohort are the freshest trainees we have who just joined the program this year, and we were excited to have them share their early work with us here. There were also submissions from the frontline trainees. These are trainees of the 3-month course, so their training is a little squashed, the field epi training, and pick some of the core competencies, but they do not go into much depth like the advanced program. So, but we did have them submit the abstracts also. In COVID, we had 3 oral presentations and 5 posters in other health security topics and outbreaks, including One Health, biotic resistance, and those other health security topics. We had 3 orals and 7 posters. We had 5 oral presentations in malaria and 7 poster presentations on malaria, and ranging from malaria clinical outcomes and recent outbreaks in malaria and and surveillance for malaria. So it was quite exciting. And we did have also 6 presentations, oral presentations in HIV and TB, and 9 poster presentations. And apart from the participants' presentations, we had 4 great keynote addresses that touched on the various areas, COVID-19, malaria, HIV, and we had some great synthesis of where we are, the successes that Rwanda has made, the priorities, and also highlights of the gaps that remain that hopefully we'll continue to look at in the coming months and years. And so at this point, I just allow me to stop there and say thank you for the discussions and the vibrancy of the discussions, and we hope to summarize this. Actually, we will summarize this, the proceedings of this conference, and make follow-up discussions with the various program areas and push this to another level and make sure it just doesn't end here. Thank you so much.
So thank you again, Dr. Jared Omolo, for that summary of 2 very exciting days with very good deliberations. And I think Dr. Jared mentions a very important item that we'll continue to summarize and hopefully even publish the key outcomes from this conference. So we are moving on to a next very exciting session. If you look at your agenda, after the summary, we are moving towards the awards for some of the outstanding presenters and others during the course of these 2 days. So these awards recognize, celebrate, and encourage different achievements. We salute and acknowledge hard work and these results. To win these awards, the participants have been endorsed by an illustrious panel of professionals in the last 2 days. We do have a number of categories that have been selected, so please sit up. You might be just that person who is getting awarded. So for first category, we are going to award our best oral presenters. So in third place, our best oral presenter in third place is Mr. Kizito Shimiman. Yes, another round of applause. Wonderful, and congratulations to you, Kizito. Yes. Okay, so moving on, we are going to announce for the same category, Best Oral Presenter. In the second place, we have Vene Maria Noela. Vene Maria Noela, please come forward to the podium. Okay, so congratulations, Noela. We are going to award Best Oral Presenter. In first place, Sekuye Olivier. All right, once again, a very warm applause for these deserved awardees for the oral presentations. So we're going to move on to the next category. For the next category, this is a category of poster presentations. So in this category, we do have two subcategories. The first being the best poster presentation at the level of the advanced course, and that goes to Jean-Paul Niyomugabo. Congratulations to you, Jean-Paul. So again, in a similar category for best poster presentation for a different category, this is a frontline course. Havugimana Shaban. Congratulations. Yes, so we invite Deje and that esteemed table to kindly walk forward so we can have a photo opportunity with the winners here. So once again, let's congratulate this group of winners. So thank you very much. You can proceed back to your seats. Yeah, so moving on, we are pleased at this time to also present a very special thank you and special award to our resident advisor for so many years. Let's hear that noise. Let's hear that noise. So we'd like to present our thank you message from the Rwandan FELTP. We'd like to welcome you, Dr. Jared Omolo, to the podium. Another round of applause for Dr. Jared. Thank you. So again, thank you so much, Gerard. I think that thank you message, that award, recognizes your hard work, your commitment to the Rwanda Fetp program for the last 10 years. Moving forward again, we would like again to give our thank you message and our award to Professor Joseph Naganira for his commitment and hard work to the Rwanda FELTP program. So, Professor Joseph, unfortunately, is not present with us this afternoon, but we have someone who's standing in for him. So, Peace will take the award on his behalf and pass to him our message of thanks and congratulations for the hard work that has been going on for the past number of years. So once again, I would like us to give a round of applause to all the worthy winners, for those in different categories, the oral presenters, the poster presenters, and of course, the other worthy awardees this afternoon. So that brings us to the end of the award ceremony, and then at this juncture, I would like to invite the Director of CDC, Dr. Thierry Roll, to give us his remarks. Welcome, Director.
Good afternoon. Director of RBC, Dr. Sabin, Executive Director of Afinet, Dr. Antura, distinguished guests, presenters, ladies and gentlemen, on behalf of the U.S. Centers for Disease Control and Prevention, I'm happy to join you for the closing ceremony of this exciting event. I don't know about you all, but I enjoyed it very much to be here, to be able to listening to some great plenary sessions and also to absorb the science. I thank all the conference organizers for the time and effort put to make this conference a success. Colleagues of the Ministry of Health and RBC, thank you so much for hosting the conference. And it was very reassuring to learn that this was one of the first major face-to-face conferences since the onset of COVID-19. Dr. Sabin just mentioned that since ICASA 2019, this has been the first health conference. And I'm sure that Dr. Antara, as one of the founding fathers of the program, must be very proud to see the state and the quality of the FETP program here in Rwanda. Congratulations to the presenters for a job well done. As we heard from Jared, 21 orals and 41 poster presentations were competitively selected from a pool of 92 abstracts submissions. That's a success rate of 68%. Well done. For those of you whose abstract was not accepted, don't feel discouraged. There will be other opportunities, and I encourage you to take it as a challenge to make your abstracts better for the next conference. Under the conference theme of building of resilient, sustainable, and innovative health systems, we had a chance to run with you upstream and got a better understanding of some of the current public challenges and issues in Rwanda. Some highlights that I took away. We listened to interesting and illuminating keynote addresses on different thematic areas. We heard presentations highlighting trainees' investigations and contributions to the COVID-19 response. In particularly, I enjoyed the cluster investigations that actually led to policy implications with closing down nightclubs where the transmission was very active. We also learned about outbreak investigations and got a chance to reflect on other health security priorities like antimicrobial resistance and One Health issues. We listened to presentations that highlighted great progress in the control of TB and malaria, but also identified possible drivers for adverse outcomes. Presentations on HIV highlighted the importance of granular data synthesis in understanding emerging clinical challenges along the HIV continuum of care. We also touched upon ethical issues. I remember yesterday when the presenter presented outbreak investigations in prisons, some tough questions on how to deal with ethical issues in populations at risk, and we got very good answers on how to tackle that. But most importantly, and as reflected in the discussions, the presentations allowed us to appreciate that every single challenge we face also has a solution. And that's the hallmark of resilience. I believe that the continued investments in public health workforce building through the FETP, among others, will provide a foundation to keep strengthening the health system. Well-trained epidemiologists can make a difference by asking the right questions, thinking about what others have not thought, and by removing the right pump handles, as John Snow did over 170 years ago. As noted by the US ambassador during the opening ceremony, complex problems require coalitions to tackle. CDC is glad to continue working with MOH and other partners to keep strengthening the health systems and other health indicators in Rwanda. Investments in HIV, malaria, health security have shown a remarkable impact. The FETP is one of the programs that CDC is proud to be associated with. In addition to the advanced FETP, CDC is supporting ongoing efforts to broaden the epidemiological pyramid through the frontline FETP. And I'm sure that with support of RBC and MOH and other partners, these efforts will maintain the momentum towards a healthier and safer Rwanda. I want to end with two thoughts. Ending outbreaks is the most important phase to do in an acute phase. But it doesn't stop there. It is also important to write up your investigations, not only for your personal merit, but so that others can learn from your investigations. So I encourage you to take some time after the acute phase of an investigation is over, to take time and to gather your thoughts and make an effort to publish it. And secondly, I hope that you will continue to form the alumni network, which is very important for a distinguished group for graduates. Think about that you could serve as mentors for the next classes that will come after you. Having a good mentor is very important for your continuing formation and education. See it as an honor badge to belong to this distinguished group of trained epidemiologists. Thanks again to the organizers, presenters, and all the participants for a great conference. I hope you enjoyed it, and I hope you learned a lot. Thank you.
Thank you so much, Dr. Thierry, for your remarks. And then moving forward, I'd like to take this opportunity to invite the Director General of Rwanda Biomedical Center, Dr. Sabin Sanzimana, to provide his closing remarks. Thank you. Good afternoon. Good afternoon. Thank you. Thank you. We need some energy. Director of CDC, Rwanda, Director of AFINET, all doctors, professors, all FTP. I used to call it FLTP. Now the L has disappeared somewhere, but it's still important. And understand there is also a V somewhere, FLTPV or FTPV. So yesterday we came here with the minister and other leaders, vice chancellor, the ambassador, and most of you. So we were all excited to be back in this beautiful building to again discuss science, epidemiology, medicine, veterinary, laboratory, face-to-face. Because there have been 2 years of interruption almost, when we could not meet face-to-face, but we were all busy fighting COVID-19 pandemic, which is still here. But at least we now know how to manage with better tools, better knowledge and skills, because most of you have been gaining experience and you've got great trainings and mentorships from the mentors who are here, from your own experience, or from different exposures. So I was really impressed by the quality of the abstracts. I got the book. I read almost all the abstracts. And some of those have been awarded the best, but they are all good. They are all good abstracts that we are all advocating that they become also manuscript and papers that we can all read very, very soon. So when this theme was presented, it captured everything you can think about the current situation. We are all building the system, the sectors, ourselves, our communities. Resilience is important because we are having a lot of pressure on our programs, on our countries, on our economies. So we need resilience in so many things. And sustainability, because we don't want to build something, then when you leave a few minutes or a few days, you look back and you see that it's no longer there. I'm sure Dr. Simon will not be happy to come back and see that what he did in 2008 is not still standing. So that is sustainability. And sustainability is not built when you're already done with what you're building. It starts when you're planning. So that's why what we're planning today, what we are discussing in these trainings is very important for what will be remaining in the next 10 years or 20 or even more. Innovation is very key because nothing is static. Everything is changing. Even the climate is changing. Even our own cells are growing. So staying static and remaining in what you've done 10 years ago is not applicable. The viruses are changing, microbes, pathogens. So innovation is very, very important. Every day we should apply it to what we do. And field epidemiology, I like the word field because it brings the work from the offices, from the theories and meeting rooms to the field where the people, where diseases and the animals are. So field epidemiology is, to me, although I did epidemiology, but I didn't do field epidemiology, but I pretend to be on field when I see that field epidemiologists are really doing a great job. So these trainings are to us a great investment, because if it was not there, last year we would be struggling to find people to send on field. But in March last year, after the first case was confirmed, we didn't even call them because they knew they have to come. So we were sitting, then we saw them coming, joining us. I can tell you at which time Vincent Mutawazi was joining. I can tell you when Dr. Mariam was coming, when Edson was coming, and even Dr. Jared joined. Although there are some regulations somewhere, I reserve that in our post-conference discussions. I think Jared and the other colleagues broke some rules and came to help because it was necessary to intervene and to show the field epidemiology you've learned and apply it when it's most needed. So thank you to all. Thank you to all behind these programs, being the brains that thought about it, from CDC, from PEPFAR funding, from AFNET support, from implementers in country, and of course the Ministry and the University of Rwanda, and I not forget RBC, that we have been working together to make it happen. So before I conclude my remarks and actually conclude this important conference, I want to highlight two things. Number one is that the trainings we've done and the people we've trained are not enough. So this must continue and be taken to another level. To me, it's just the beginning. There are levels, there are categories, there are higher expectations. And those who have been trained, don't say that you've done your trainings. It's time to relax and wait for the next conference. So what you're going to do after here is more important than what you've been doing before. So let's take it to another level. Let's train more people and even increase the level or the quality of training you're providing. There's already good quality, but the expectations are much higher. If we think of another pandemic coming, I don't know, but there's no one who can say that there's no other pandemic or other viruses that is going to hit us in the next months or years. So what we are going to do is another investment for the next decade or more, and we can't wait or even delay these actions. I already had a great meeting with Dr. Simon before the conference starts, and we have agreed on key areas that we are going to work together, the Minister of Health and RBC and partners, CDC. I'm sure we'll have more discussions on this as well. But let's prepare for the next pandemics. Let's also sustain our efforts that we've invested. I can imagine how many nights that FLTP trainees or experts didn't go to bed on time. They're still fighting in the lab, on field, in testing sites, in command posts. They're all probably tired, but the reward and the satisfaction professionally they feel, it's the courage that takes them the next day. But they need more people behind them, younger people, young ones who take the next challenge, but they remain also as mentors for the next cohorts that will keep coming. And not only for Rwanda, we are happy to see other countries being supported, those who do not have enough skills. We want to see also those who have people are trained to another level coming to share their experience with us, like Dr. Simon is doing here, like Gerard and others. So this exchange is needed now more than before, and we have different frameworks that were created through this pandemic. So I want to advocate for that. We train more people, not for border limits, because these diseases actually do not have borders. So I thank you so much on behalf of the Ministry of Health and on behalf of Rwanda Biomedical Center. We thank our partners who have made this program start and still sustain. Let's keep on it together. With this, I thank you and declare this conference closed. Murakoze, thank you.